All right. Good morning, everyone. Appreciate you joining us. I'm going to call the meeting to order now. Please note that the meeting is being recorded. And now I'll ask for a roll call.
Good morning. Joan Allen.
Present.
And as a reminder to everybody, please speak into the microphone and press the button so that the light turns green. Barry Arbuckle.
Present.
Eliza Arjoyan.
Present.
Stephanie Klein. Carmen Comsty. Adam Daughtry. Parker Duncan Diaz.
Present.
Hector Flores. Sarah Gavin.
Present.
Stacy Hratas.
Present.
David Joyner.
Present.
Ivana Krasinovich. Tam Ma. Carolyn Nava.
Present.
Mike O'Day. Janice O'Malley. Sumana Reddy.
Present.
Yolanda Richardson. Kieran Savage Sangwan.
Present.
Andrew C.
Present.
Sarah Srokin. Ken Stewart.
Present.
Suzanne Usage. Yvonne Wagner. Renee Williams. Anthony Wright.
Good morning.
Abby Yount. Anybody that came late that I didn't call your name? Yep, please, Tam Ma. Thank you, Tam.
And Carmen Comsty.
Perfect. Thank you very much. Appreciate that. With that, we have a record of who's in attendance. Again, good morning. My name is Scott Chrisman. I'm Chief Deputy Director here at Department of Healthcare Access and Information, sitting in for Director Landsberg today. Before we get started on the agenda, I'd like to introduce our attending board member, Ian Lewis. Thank you, Ian. His role today is to listen to the presentations and discussions of the committee. Next, I'd like to introduce Brian Kearns, member of the OCA legal team, who will be filling in for Danielle Rogers today. And then finally, I'll introduce our co-facilitator. We are working with Leading Resources to include an external, neutral third party to facilitate our committee meetings. This allows for staff, members, and presenters to fully participate in the discussions and help us move through all of our agenda items. Very glad to have Jane Harrington with us today. Thank you, Jane. Okay. Next, as we review the agenda, I'd like to note on the agenda that we'll be moving item 4, consumer stories on affordability, to the February meeting. And with that, I'm going to move into executive updates quickly. So I'd like to start with a budget update. As you're aware, earlier this month, Governor Newsom released his proposed budget for the 24-25 fiscal year. As with last year's budget, this year's also includes a deficit. The governor's proposed budget for FY 24-25 is $291.5 billion, with an estimated $37.9 billion deficit. While the administration is proposing changes to offset the deficit, the budget does preserve core state programs and still provides the ability to continue implementing new investments in future years. For HCI, this means that, again, some of our health workforce development programs in particular will face delays in some program funding. About $140 million across nursing and social work initiatives, specifically $70 million each, is proposed for delay, as well as a delay of about $189 million for various behavioral health programs. There are some bright spots in the budget for HCI, and our overall budget for fiscal year 24-25 is $523 million, with 748 authorized positions, which represents another year of growth for this department. After updated budget numbers are released with the May revision and negotiations take place with the legislature, the final budget must be signed by June 30th for fiscal year that begins July 1. So there's quite a bit of work left in this cycle. All right, moving on to some HCI program updates to share with you. First, the Distressed Hospital Loan Program. This is a program that offers interest-free working capital loans to nonprofit and publicly operated financially distressed hospitals in California that face the risk of closure. The loans provide financial supports to these hospitals as they implement strategies to regain financial stability. To date, the Distressed Hospital Loan Program has distributed $182.5 million of the $300 million allocated to loans. This has gone to 10 hospitals. Additional 6 hospitals are working on completing all of their transaction documents in order to receive their loan distributions. Next, the Healthcare Payments Database data program is in the process of finalizing a third pharmaceutical cost data visualization that will be released shortly, adding to the existing suite of public HPD data products that include the HPD snapshots and HPD measures. In addition, the data access and release regulations for the HPD program have been re-released for a second round of public comment, which closes on February 1st. HCI is also required to issue a formal report that details data quality in the healthcare payments database. The report will be released by March 1st, comes in the form of a report to the legislature. And finally, the Health Workforce Development Program has recently launched a certified wellness coach website for prospective employers, students, or individuals interested in pursuing a career in behavioral health to learn more about this new profession that HCI developed through the Children and Youth Behavioral Health Initiative. The website is cawellnesscoach.org if you want to check it out. The Certified Wellness Coach Employer Support Grant Program, that's a mouthful, launched last week to provide grant funding to school-based and school-linked community-based organizations, local education agencies, county offices of education, and school-based education agencies to recruit, employ, and build capacity for certified wellness coaches. HCI also recently announced scholarship awards through 2 new behavioral health workforce programs. The Behavioral Health Scholarship Program awarded 461 students over $10 million to pursue their behavioral health degrees and practice in an underserved community or serve underserved populations on graduation from the programs. The Golden State Social Opportunities Program awarded 149 students scholarships totaling over $5 million to support students pursuing licensed behavioral health professions in exchange for a service obligation of 24 months at a California-based nonprofit community-based organization. So lots going on. Happy to share those updates. None of these programs were impacted by budget delays. And with that, I'm going to turn it over to Deputy Director Pagani to share more updates.
Thank you, Scott. So as we do at every meeting, I'd like to remind the committee about our slide formatting key. We use a blue arrow in the presentation for areas that the advisory committee provides input or recommendations on based on statute and other areas requested by the board or OCA. And next, we'll review our quarterly work plan and future topics under consideration. So the items listed for January are consistent with the agenda for this meeting, except for consumer stories on affordability, which we'll cover in February. I will also shortly cover updates related to our cost and market impact review program and provide a progress update on OCA's work streams for alternative payment models and primary care. In February, we plan to bring additional examples of cost reducing strategies. These are strategies that healthcare entities employ to reduce costs while maintaining access and quality and equity. And we'll also discuss additional items with the board in that month. These include consumer affordability measures, specifically the impact of program the OCA program on affordability for consumers and purchasers of healthcare. We'll also follow up on the proposed spending target. And in March, we'll discuss with the board public comments received on the proposed spending target. We'll also share with them the draft alternative payment model definitions, data collection approach, and goals and standards. Next slide. So this slide covers our tentative list of future topics beyond March. For total healthcare expenditure and spending target, I'd like to call out measuring out-of-pocket spending. We heard feedback from many of you about the importance of tracking spending by consumers that happen outside of their health coverage. We are looking into medical expenditure panel survey data to see if we can provide some directional estimates on this category of spending. For promoting high value, the board will have several decisions to make early this summer about alternative payment model standards and the adoption goal. The board will also adopt benchmarks for primary care spending. OCA will also review final workforce stability standards early summer. Later in this meeting, you'll be hearing about our progress update on the workforce stability standards. For addressing market consolidation, we'll provide the board updates on material change notices received, transactions receiving waiver or warranting a CMIR, and timing of reviews for notices and CMIRs. Next slide. So I want to just give you a brief overview of the advisory committee member selection timeline. So where we're at in the process is that a subcommittee was established at the last December board meeting. Dr. Richard Pan and Elizabeth Mitchell are on that subcommittee. So we have some continuity in the board members that are involved in appointing, recommending advisory committee members to the board. We will be releasing a submission form in the next month, and then we'll allow some time for interested parties to put forth their submission form. And then during the months of March through May, the subcommittee will meet and review those submissions. And then in June, the board will appoint or reappoint members. And for those in the next slide, I'll be sure, for those of you that are up for, your appointment date was only 1 year, we will be providing you the information that you submitted in last year's submission form so that you could reapply. And then in September, that would be the first meeting for any new members that are added to the advisory committee. But given some of the comments we heard at the board level, there is a lot of interest in continuity. So we'll be reaching out to current incumbents about what information you'll need to put out in the submission form. Next slide. So I'll be providing some branch updates. OCA has three branches: the healthcare spending targets branch, the health system compliance branch, which looks at market consolidation, and then health system performance, which is all the balancing measures aside from cost. So for market consolidation, I do want to note that on the next slide, our material change notice portal, well, first, our regulations were effective December 18th. So they're in place now. And then shortly after that, we activated our portal for healthcare entities to submit notices of proposed transactions. It's located on the HCI website. There's a direct link, and we sent notification to our listserv that it's now live. Next slide. So in terms of reviews of material change transactions going forward, material change transactions will be reviewed by OCA staff with assistance from economic experts as needed. Notices will be posted on OCA's website. If warranted, transactions will undergo a cost and market impact review. Any CMIR will result in a preliminary report, which the parties and the public can review and comment on before a final report is issued. And then OCA will regularly report to the board some data points on notices received, the timing of how long it's taking to complete a CMIR, et cetera. I'll now move on to updates for the health system performance branch of OCA. So there are 5 areas within the health system performance component of OCA which promotes a high-value healthcare system. This ensures a balanced approach to slowing spending growth. Under the statute, the intent is not to simply have a low-cost system, but to take the best ideas and reorient the healthcare system towards greater value. Today, I'll be providing some updates on APM adoption, primary care investment, and then later in the meeting, you'll hear from Assistant Deputy Director Brandt about workforce stability. Next slide. So this slide shows our work group members. Similar to the advisory committee here today, we also have a broad cross-section of industry, purchasers, consumer representatives and advocates, and academic subject matter experts. Next slide. So these are the topics that the work group engages on during its monthly meetings. Broadly, the work group helps ensure stakeholder engagement in key OCA program development decisions about definitions and data collection. The work group provides input and feedback as OCA develops recommendations for benchmarks. The work group also helps identify and discuss the relationships and interactions between APMs, primary care, and behavioral health. Next slide. I'll now provide a progress update on our APM standards and adoption goals. So OCA has worked with the investment and payment work group from June through November of last year to develop draft standards for APM contracting and draft APM adoption goals. These were presented to you all in our November meeting. We are in the process of revising the draft standards and adoption goals based on advisory committee feedback and are debriefing the work group. And then we'll present the draft standards and adoption goals to the board in March for feedback and release for public comment. Next slide. So this figure summarizes the updates that I just shared with you. As you'll see, we're working towards a June 2024 goal for board adoption of the APM standards and adoption goals. So there'll be a time period between March and June where we'll be receiving board input, public comment, but the end goal is hopefully to get approval by the board in June. Next slide. And I'll now provide an update on primary care investment progress. We started discussions of primary care spending in the investment and payment work group last November. This included launching a technical subgroup to support the development of the definition of primary care. The subgroup met in November and December 2023 and January of this year. They considered primary care definitions used in other states. They developed a draft definition of providers, sites of service, and services for claims-based primary care spend. From having listened to some of these meetings, I can attest that this was a robust discussion, and there are differing points of view, especially when it comes to provider types that count as primary care, and settings. Whether retail clinics can be considered settings for counting primary care spend. The work group also discussed approaches to measuring non-claims based primary care spending. OCA will bring proposals from the subgroup to that larger investment and payment work group for further discussions this winter and spring. OCA will present primary care investment benchmark recommendations to the board in May 2024 for feedback and public comment. And then the next slide similarly gives kind of a nice summary of the key milestones in our timeline. The end goal is to have board adoption of the primary care spending benchmark by July of 2024. And then I'll be skipping over the next two slides on workforce stability because you'll get a more detailed update from Margareta later. And with that, I'll turn it back over to the facilitator.
Great, thank you for those updates. Does the committee have any questions? All right, seeing none at this time, we'll now move to public comment. We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to public comment, we will alternate between members of the public in the room and those virtual. Those in the room may line up at the podium. Those attending virtually, please raise your hand. If you're dialing into this meeting and would like to provide public comment, we ask that you submit your comments via email or join the meeting online if you would like to make public comment. If possible, please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the committee is committed to communication and transparency, committee members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I'll start with individuals in the room, seeing no one at the podium. Looking online, noting that we have roughly 50 virtual attendees, seeing no hands raised at this time. Back in the room, no one at the podium. That concludes public comment on this item. No.
You mentioned the material changed went online. Have we gotten any submissions yet, or is that still too early? I know it's been only a couple of weeks.
Yeah, it's too early to tell. We have not received any notices. We have, people have asked us questions to our inbox. Yeah.
Thank you.
All right, that takes us to our next agenda item.
So this is the agenda item for spending target methodology and statewide target value. Before we dive in, I want to, we have a number of topics to discuss in the interests of keeping us moving. I'm going to ask Jane to note when we're at time for each of these items and encourage us to move on to the next item. So we'll be starting with some updates from some topics related to the December board meeting. I'll turn it over to Michael to cover the first set of topics.
Hi, everyone, nice to see you. So the presentation I'm going to give now is just a few slides. It's on the topic of whether or not the spending target should be adjusted for healthcare technology. This is a question that arose in the October meeting of the board and was discussed at its most recent meeting. So I'm going to summarize the information that I shared with them, and then Vishal will invite your comment. I do not have a magic button, so Marco, can you help? Thanks. Okay, so the statute specifically says that in developing the healthcare spending target methodologies, there should be consideration of factors to adjust future cost targets, including trends in the price of healthcare technologies. First, I'll note the language says future cost targets, not the initial ones that were set. I'm not sure why it was drafted that way. And two, it does not define healthcare technologies, so that's left for us to consider. During the December board meeting, the board discussed the prospect of making adjustments for technology and discussed first a definition of what we mean by healthcare technology, and we presented a definition from the World Health Organization for consideration. And then we shared information both on healthcare technology and its impact on spending, and then separately the price of healthcare technologies, because that's the language that's in the statute. Next slide, please. So healthcare technology, or technology, I would say in general, can produce savings, short-term and long-term. It can also increase spending. The impact of technology is that the costs will be borne by provider organizations. Of course, savings can also be realized by provider organizations. To the extent that there are costs that are borne, sometimes they might be reimbursable, sometimes they might not be reimbursable. As we talked about whether there should be an adjustment to the spending target for technology, we considered the need for OCA to be able to predict the cost impact of new technology, and even to predict the development of new technology. And so that is separate and apart from the need to anticipate what might be the prices associated with new technology. So overall, our assessment is that it would be extremely challenging to build into the spending target that's being forecast out multiple years what yet undeveloped technology might mean for healthcare spending, either in terms of an upward pressure or a downward pressure. That's not to say the technology won't have an impact on healthcare spending. It's just that being able to anticipate what the impact will be is extremely difficult. Next slide, Marco. So to give you some context, none of the other states with spending targets have adjusted their targets for technology. There are a couple of examples, though, where states, when reporting performance against the spending target, so this is obviously retrospective as opposed to prospective, which is what we're talking about when we're talking about adjustments. Retrospectively, they have contextualized performance against their spending target by noting the impact that technology had. And I believe that at least on a couple of occasions, Vishal has given the example of spending on Sovaldi in Massachusetts, which contributed to a big spike in 1 year. And the assessment of the state when looking at spending said, you know what, we exceeded our spending target this year, but it was for a good reason. And so we're going to be satisfied with our performance that exceeded the spending target because of the impact of a very positive technology on the health status of state residents. Okay, I was going to pause for Vishal, but he walked out of the room. So CJ, it's left with you.
I think we can pause and just see if there's any further discussions or questions from the advisory committee at this point.
Andrew?
Yeah, just quick question, and maybe I'm just coming, help me understand, right? So there are things like just unknown, right? You just can't predict that it will happen. But there are items like, and I'm just going to pick on GLP-1s, right? It's the topic du jour. Pharma, has a pipeline, and generally folks really monitor that. There are fairly large effects of it. So I guess I'm, thinking about an adjustment for something that it's not quite unknown, but it's still unknown, but you know it's coming.
Right.
So I guess I'm just trying to get your thoughts on that.
Right. So we know that there's spending coming through pharmaceutical development. And we know that the price points of new drugs that are being introduced are way higher than what they've been historically. So you're right. That's a known unknown. What we do not know specifically is to what extent when those drugs are introduced are going to be approved by the FDA, or health plans like your own are going to decide to cover them, because that's going to influence the impact that they're going to have on spend. So this is just my personal opinion, not that of OCA. It is that we should be aware that pharmaceuticals are likely to impact spending growth in the state, and we should be monitoring them and assessing their impact retrospectively when we're assessing performance against the spending target.
Yeah, so I guess I would just say that, so just think about incentives of what that would create, right? So if the target is, let's just call it the number that's on the table, which is 3%, you know, what I'm hearing you say is maybe retrospectively you get forgiveness from it, which is kind of, I don't know how that sounds, but I get these prospectively, if somebody really wants to hit that 3%, you know, you're creating an incentive to, you know, control, not cover, whatever you want to call it, some of these new technologies. Just we just have to all be aware of the incentives it creates.
Mm-hmm. Yeah, and maybe it would be appropriate in more real time for there to be a discussion by OCA and the board as new technologies are introduced, or not. I'm not going to weigh in on that, but what I am saying is we don't know what's going to be introduced to the market next year. So because of that, it's hard to even quantify what an adjustment might be if we wanted to make an adjustment at all.
So I guess I'll say I hear you, but we have one big item, right? The GLP-1s. It's a known. Can we quantify it? Not sure, right? I mean, everybody's trends are kind of doing this. So I just
well, and can we quantify it for the time period, you know, 2027 going out 5 years, right? Because we're not talking about quantifying it for 2024. We're talking about quantifying it going out multiple years. That's the challenge. So I hear you. I'm not sure I've given you a fully satisfying response, but it's the best I can offer.
Okay, we've got Sarah and then David.
I was thinking that if we even consider adjusting based on adjusting for technology, we would have to consider adjusting down as well, because I'm thinking like in behavioral health, if new drugs come out that are more effective, that should reduce costs, you know, improve outcomes. And I'm also thinking just in general, a lot of the, you know, electronic medical records and AI, all of those things are supposed to increase productivity. So we'd have to not just look at how technology will cost us more, but yeah.
Thank you, David.
I'm just going to go a bit further on Andrew's point. So first of all, like personally, I'm not a big believer in trying to set premium or revenue targets as a way of controlling the market, but I know that's what we're trying to do here. And so therefore, the way I get comfortable with this is I say if we set the target intelligently, so that we can say it's set in a way that kind of adjusts for what we understand, then I feel better about this notion. And the thing I have trouble with in this case is we all know that there's a couple of big categories, specialty drugs I'll pick on since Andrew started there, that we know today the cost of those is going up much faster than the sort of 3% thing that's been thrown out here. And nobody in California can control that because those prices are set out of our control, right? And I think that going down the road of saying we're going to set a target, and maybe retrospectively we're going to look at adjusting for those things, I think is the wrong way to approach it, because we know today It's a big cost factor. We know it's going up much faster than household income. And as a provider, my capitation payments from a health plan that I negotiate include an allowance for things like this. Or if I'm a hospital, my per diems will include an allowance for things like this are going up much faster than inflation.
Mm-hmm.
And so in my opinion, we should be thinking about proactively including factors for things that are outside of the control of the provider organizations that are going to be held accountable to these targets. And we know, as Andrew already pointed out very, very well, we know what some of those are. I think saying we don't know what they are is kind of a cop-out, because you've gone back historically to come up with the prospective target. We could go back historically, you can see for years that specialty drugs have gone up much faster than inflation. And so I think we should be adjusting the target for the known technology changes that we have a trend and experience. And I recognize your point is, what if there's a technology we don't know anything about today, like COVID would be a good example, a factor that came in that nobody expected. I understand we can't predict that, can't plan for that. Maybe retrospectively we'll look at that. But I would say there are some components of technology where we know there are known costs, there's a known trend. And so I think we should be adjusting for the targets that are set to reflect that. And otherwise, in a price-constrained environment, you get the unintended consequences, which is providers or health plans will try to limit access to those things to try to manage the costs. And I think that can be very damaging.
So David, I want to follow up just a little bit. So is your recommendation to look specifically at what trend for brand name drugs has been the last 5-10 years and then project that forward?
So brand name drugs is a big category. I was actually focusing on specialty drugs, but I would pick that. I think there's 3 or 4 categories of drug and devices, and I would look at historically what the trend has been over the past 5 years, and I would include that in your calculation of what the go forward targets should be.
Okay, thanks.
All right, we've got Samantha, Parker, Joan, and then Carmen.
On the clinical comment side around that, we have veered from technology to the business of pharmacy. And in thinking about that, and I know this is somewhat outside of the purview of this committee, but on the federal level, we've had comparative outcomes research that really has been inadequately supported over decades, right? So as we come up with new biologics and potentially groundbreaking new drugs, including the ones that are in the pipeline now, if we don't, as a country and state, support the research and promulgation of the outcomes of that research, we're not going to have the ability to control that spend. That's true, but it shouldn't be on an individual systems level. It really needs to be on the level where we get a better grasp. And I bring that up because I was just looking at some of the state legislation around, insurers having to pay for pharmacogenetics testing. Well, so far, that kind of testing hasn't panned out to be of clinical benefit, actually. So who is pushing for that legislation? And what benefit is it on the ground for patients and clinicians trying to make these decisions, right? So I kind of want to bring it back to that and say, that's where if we have the actionable information we need, then we can hopefully make the decisions around where the costs save lives or improve, provide benefit, as Sarah was pointing out, and where they may not.
Thank you. Parker, Joan, and then Carmen.
Perhaps similar comment, and this is also a bit of a reflection on the notes as I was reviewing from last time. From the patient perspective and I'm a primary care doc, family doc, we still know that the number one technology employed in any functioning healthcare system is primary care. And the more effectively you promote that and implement that related to Samani, like we are trained to know what is best to implement for which patients. And so while that might not exactly address this topic, it gets back to the point that I think we talked about last time too, which is it's not so much about the total spend, it's about, are we going to design ways to spend smarter and spend better? As we know that primary care is the only thing in healthcare that's a common good, in that the more you spend on it, the better health gets, and actually the long-term costs go down. So that remains, in my mind, still kind of the number one underused technology, if you will, in healthcare. So the more we talk about investing in that, that is also a factor there. So I think my punchline comment is it's still technology is also about spending smarter, not just looking at the fancy new toys that come down the line.
Thank you, Joan, Carmen, and then Barry.
I really appreciated the board's discussion about retrospective looks at technology, and feel like that's really the right direction to go, at least for now, partially because for the first 5 years, we're looking at a statewide spending target. And any technology, whether it is a pharmaceutical, AI, God help us, or any other new unknown, is going to impact different parts of the sector differently. And so some hot new specialty drug that dramatically increases the cost of treating, but dramatically increases outcomes for a particular group of patients may have no impact or even a cost lowering impact on other parts of the system. And so the idea of, while we're under these statewide spending targets, of trying to do any kind of adjustment for technology as a prospective just feels like it's going to create real inequalities in the system. And we have the time to let this play out. Once we get to the sector-specific targets and the entity-specific targets, that will be the time to have this conversation, not while we're talking about statewide.
Thank you, Carmen, Barry, then Anthony.
Yes, thanks for the discussion on this. Similar to what Joan was saying, I think, we don't want to get trapped in this this idea of trying to speculate the potential use and costs of new technologies or pharmaceutical products, because we could be creating market incentives for those outside, what we're saying are out of the control of providers. We don't want those outside markets to react to California saying, hey, look, we have an adjustment here that is willing to bear increased costs in technology, and therefore they'll push the prices up as much as California will bear. I think that's really highly problematic to do the prospective kind of calculations here, because we might be creating the inevitable of either inappropriate use of certain, if we're talking about pharmaceuticals, certain pharmaceuticals or certain technologies, and the inappropriate kind of pushing the prices upward if we're essentially showing our cards to the technology producers, the pharmaceutical companies. I think we need to really, because they are unknowns, known unknowns, that I know, who knew this, however many years later we'd all be using the term. Anyways, I think, we should take to heart that we can't actually calculate what's going to happen until patients actually need certain types of products and technologies. And there's two things going on. There's that we don't want to put our patients in the space where they are inappropriately being pushed towards a technology, towards a pharmaceutical product, and we also don't want to push the prices upwards inadvertently.
Thank you, Barry, then Anthony.
Just two clarifications. One, Michael, when you started, you were citing from the sector and saying that there would be some, or could be some consideration for adjusting targets for technology that we're discussing, but not for the currently set targets, but for future. Which is to say, if we set 5-year targets until 2029, there won't be any consideration until 2030? That's how I interpret it. Is that what you're saying?
Yes.
Wow. Okay, knowing they're going to come every year and escalate on each other and compound.
Yeah.
Okay, we know what that means. That means that there's going to be a whole lot of explorations.
But
and
I'm saying yes, not in terms of the compounding. I'm saying yes in terms of the time period.
2030
That if
would be
we
the first
interpret
time.
the statute as saying it's future targets, not the initial targets.
I didn't know if that meant the second year or after the first 5 years. I didn't know what that meant.
I'm not going to interpret that, Barry, because I don't
Okay.
feel qualified to do so.
An attorney.
Okay.
Second
if I
question, and just a clarification, if I may, from Joan, and that it's statewide targets until 2030. There is no sector or entity targets, or
The
even
board has flexibility
Okay.
to establish sector targets.
within that.
The
first 5 years.
statute says here's a date for sector targets, but there's no prohibition about considering them before that.
Very good. Thank you.
Yeah, that's all that I wanted to correct was that while we're talking about setting an initial target for 5 years, one, the board does retain the authority to potentially modify within that 5-year period, and there is a potential scenario that unfolds in the coming 5 years where the board is setting sector targets before 2029.
Thank you. We've got Anthony and then Andrew.
Yeah, I wanted to support the comments of that. You know, when I think of technology, most people, in most, if not all cases, technologies that are promised are technologies that are promised to save money, and now that doesn't always turn out to be the case, but that's often the promise and why the investments are made. And I don't know if we would want to make adjustments in either direction or go into the complexity of that. I agree also, not just with Sarah's comment, but John's comment about the fact that this is that these impacts will be different in different parts of the sector of the different parts of the system, and so I think we want to be mindful of that. That in fact that there is differences between how a technology will affect one part of the system versus another, and frankly, you also would like similar to the incentives in competitive systems. If a new technology comes, there will be some actors who integrate that technology efficiently and effectively and well, and others that do so less so. And so to prejudge that would be hard. And I think the office, in providing a space for the conversation about statewide spending broadly, could be a useful space to have at least a conversation about how and to provide some information sharing to the industry about what is how different parts of the system are struggling with different aspects of either new technologies, interventions, etc. It is frustrating that there is a part of the healthcare sector that is outside of the state's purview with regard to prescription drug costs, and it's something that we've worked on a lot, and HCI has been involved with regard to its prescription drug price transparency and other work, and we need to continue to do that. And so we need to be mindful of that, and hopefully use the office as a platform to think of strategies to deal with that, you know, on a different track. But that's to deal with the specific issue of pharmaceutical technologies. But I do think that having the more understanding that there's some flexibility more in the back end than on the front end is the appropriate strategy here.
Anthony, I want to respond to your comment and just note that one of the results of spending targets in other states has been to shine a light on where is spending growing fastest, and then to energize some policy focus on those areas. So if you all conclude that a major driver is drugs and drug prices, then maybe that will mobilize some greater policy attention there.
Thank you, Andrew.
Yeah, so I'm not going to belabor the point on prospective versus retrospective, but to me, retrospective sounds like a giant carve out, a giant exemption. I'm just going to say it for pharmaceutical drugs and stuff like that, because retrospectively we can just say it's that guy, and we all knew going in that that guy. So what's our incentive to manage this prospectively if I'm going to get a hall pass up on the back end for that guy? So that's just.
So I want to recognize we've heard a range of opinions, as we did on every other topic the last time we met. But I especially want to know both Andrew and David's, their voices that there should be some adjustment. David gave it actually a specific proposal. So I want to recognize that among the range of perspectives you've all voiced here. Ready to move on? Michelle, do you want to introduce this topic? Or CJ, are you doing so?
Michael, you could take this topic. At the board level, board members requested some summary data on performance of other states against a spending target, and Michael will cover these slides.
Okay, so I'll say as an opener, the onset of COVID-19 has made it challenging to look at performance under spending targets because Massachusetts' spending target became effective in 2013. There were no other state spending targets until effectively 2019. And then we know what happened in 2020. So we've got some highly distorted data from several states. These were sort of the replication states. It's only for Massachusetts that we have extended performance information that predates COVID-19. So I'm going to share that information first, and then I'm going to share with you what was experienced 2019 to 2021, both in Massachusetts, but also in the other spending target states, or at least those that have reported so far. Okay, next slide, please. So as I just said, Massachusetts was first. Its spending growth between 2012 and 2021 was 3.5% per year on average, which is below their initial target of 3.6%. They also reported on annualized spending growth for 2019 to 2021. So that means that accounts for the drop in per capita spending in 2020, because as a reminder, in state spending target programs, all those federal dollars that flowed out were not captured by states because they had no means to get that information. So if you exclude the dollars that mostly went to hospitals and some to FQHCs, per capita spending dropped in 2020, and then rocketed up in 2021. So it annualized to about 3.2% in Massachusetts, and as you can see here, they had a decline in 2020 and a big increase in 2021. I will say that across multiple states, the increase in 2021 was driven by utilization. That was highly atypical because in the years prior to 2021, spending growth, particularly in the commercial market, was driven overwhelmingly by price increases and not by utilization. But that was not the case in 21. Utilization increases in 21 were phenomenally high, especially in hospital, outpatient department, and professional. Next slide, please. So this is a graph that shows Massachusetts performance. I want to note that for Massachusetts, and I shared this with you, I think perhaps at our very first meeting, that prior to the establishment of Massachusetts spending target, Massachusetts per capita annual spending growth in the commercial market was above the national average for 6 out of 7 years. Upon the effective date of their spending target, their commercial per capita spending growth was below the national average for 7 straight years. So above for 6 out of 7 years, and then below for 7 straight years. That changed in 2021 when their spending growth went above the national commercial rate. Okay, but for for that until that time period, they were on a run, and the spending target appeared to be having some impact. Now, spending didn't decline; it was growing, but it wasn't growing as fast relative to benchmark, which is the nation, as it had been. Next slide, please. So now I'm going to focus a little bit on just what happened for the years 2020 and 2021.
So can I just ask a question about that chart?
Yeah, please.
Sorry. What are the little circles without the 9% and the negative 2.3?
David, will you excuse me if I go and stand in front of the graph for a minute, since I can't see it from here?
No. Michael, speak into the microphone.
So I'm not sure why those are hollow, but those are the values for 2020 and 2021. Okay, and then the dark blue dot is an averaging over. Yeah.
Just one more question. I think while you were speaking about Massachusetts and the change, their performance.
Yeah.
You said commercial.
Commercial.
But in overall healthcare spending per capita, Massachusetts in the last 15 years, according to the Kaiser Family Foundation, has never not been in the top 5 in the U.S. Whereas California.
For total spending.
Yes.
Yeah.
Okay.
Yeah. So when Massachusetts started this, it was the most expensive state in the country.
Yeah.
Right. So, I mean, maybe it's a modest success, but they've been counting their success by saying, we're not first anymore. Now we're second. We're dropping down to third. Okay.
It's all relative.
Yeah, well, but that's also what's happening when you are modestly, or I shouldn't say modestly, if you're bringing down trend, you're not cutting spending out of the system. You're just slowing the rate of growth. So Massachusetts was never going to go from most expensive in the country to even to the median or mean in any short time period.
But one could argue when you have fat in the system, as one could argue that ones in the top 5 would have, more opportunity to reduce cost as compared to California, which has never been above the median.
Yeah.
In those same surveys.
Yeah, I'm not going to comment on whether the high spending in Massachusetts is due to fat or due to other factors.
Fair enough.
Okay. Okay, so for 2020 and 2021, and I will note that very shortly the states will be reporting on their 2022 performance, and I'll give you a little preview of what I'm seeing there. But for 2020 and 21, only Rhode Island met its cost growth target for the 2 years. Okay, meaning if we net the decrease in 2020 and the increase in 2021, they met their target. Oregon essentially they were off by 0.1 percentage points. The others missed by 3 to 8 percentage points. And that was uniformly because of growth in the commercial market. There was enormous variation, actually 100% variation in growth rate in the commercial markets across the spending target states for 2021 growth. And as I said earlier, the growth in 2021 was primarily due to utilization growth. That's not to say that prices didn't grow. They did, but that was not the primary reason for the high rates of growth in 2021. Understandably, there was a lot of deferred care from 2020 and 2021.
Outpatient hospital services. At first, I thought that was like surgical procedures, but that could also be the clinics, specialty, or primary care that a hospital runs. Do you have a?
So most hospital outpatient spend falls into about a handful of categories. So ambulatory surgery is certainly one. And we've seen dramatically the last couple of years a lot of spend move on joint replacement from inpatient to outpatient. But it also includes emergency department spending, imaging, laboratory, administered drugs. Okay, those are all big categories. There are other categories too, but those are the big spend categories. Any other questions on any of the information I've shared? Okay.
Thank you, Michael. All right, I'll just be going over relatively quickly a timeline for the process for adopting the initial statewide spending target, specifically with 2025. And we know that the office has released its initial proposal and recommendation setting the target for the first 5 years. So quick overview of the statute. Section, so 127502, section M1, essentially the board will hold a meeting to discuss the office's recommendations. And it can consider input, or will consider input from the office, the advisory committee, and the public. So before it can have that meeting though, the office, section 2, the office shall publish its initial recommendation on or before March 1st. We've met that deadline, having posted on our website last week the initial recommendation and methodology for establishing the initial set of targets. Following the release of the initial recommendation, the board shall receive public comment for a period of 45 days. That will commence tomorrow after the board has its initial discussion of the office's proposal. And then the earliest that the board would be able to adopt an initial statewide spending target would be upon the conclusion of that 45 days and waiting at least one board meeting. So there'll actually be two. That would be the February and the March meeting in this case. So the soonest that the board would adopt a target could be in March, though shall adopt the target on or before June 1. So all that said a different way, on January 17th, the office posted its recommended proposed target and methodology. We're having a discussion of that proposed methodology here today with the advisory committee. The board will discuss the proposed target tomorrow. There will be a subsequent board meeting in February. The 45-day comment period would close on March 11th, and then at a board meeting after March 11th, but before June 1st, the board shall adopt a final target. And because at one time in my life I was a teacher, I find that I like to repeat myself. So wrapping this all up again one other way. Tomorrow the office is presenting the board discussion of its recommendation, and the board will discuss. The board is required to discuss the recommendation of the office at the board meeting on or before March 1st. So that'll happen tomorrow, well ahead of March 1. The 45-day comment period will be open, closing March 11th, and then the board is required to adopt the final target by June 1st. The final target, for clarity though, may be the office's recommendation, may align with the office's recommendation, or it could be another value as discussed and determined by the board. With that, I believe.
Thank you, CJ. So before we launch into the spending target recommendation, I want to recap some data on affordability challenges in California. I've shared this before. We've presented on it. This figure shows average healthcare spending growing from about $2,700 in 1991 to $10,300 per capita in 2020. This translates to a 4.8% annual growth rate between that 30-year period, 1991 to 2020. And we've also included some data here from the Kaiser Family Foundation at the national level on employer premiums, because premium trend data for California only goes back to 2013. So we're referencing national data here, but the trend for California mirrors the national trend. In 2020, the average annual premium for employer-sponsored family coverage was approximately $24,000 and approximately $8,400 for single coverage. Some have compared the cost burden of family premiums as equivalent to purchasing a Toyota Corolla compact car each year. And it's not just premiums that have increased dramatically. part of the cost shifting to consumers is through plans with higher and higher deductibles. Here we see the growth of family deductibles, which have quadrupled in the last 2 decades. Employers with less than 50 employees are indicated in the yellow line, which saw a 10% annual growth rate, and employers with 50 employees or more saw a 9% annual growth rate, as shown in the gray line. A 2023 survey commissioned by CHCF, or California Healthcare Foundation, found that more than half of Californians, and more than 2/3 of those with lower incomes, defined as under 200% of the poverty line, reported skipping or delaying at least one kind of healthcare service due to cost in the last 12 months. And then among those who reported skipping or delaying care due to cost, about half report that their conditions worsened as a result. This figure shows that the high cost of healthcare disproportionately affects Black and Latino Californians, of which respectively 36% and 40% report that they had problems or were unable to pay medical bills. In contrast, only 20% of white Californians report these concerns. Black and Latinx consumers are also more likely to report that they or a family member skipped care because of costs, as shown in the orange and gray bars. So having covered the human toll of the high cost of healthcare, I am now turning to what the literature says about opportunities for savings in our healthcare system. As many of you are aware, there was a landmark report in 2020 from the Institute of Medicine. In the report, they identify 6 waste domains as follows: failure of care delivery, failure of care coordination, overtreatment, pricing failure, fraud and abuse, and administrative complexity. Research by Schrank and colleagues examined these 6 waste domains, concluding that implementation of effective measures to eliminate waste represents an opportunity to reduce the continued increases in U.S. healthcare expenditures. They estimated that approximately 25% of national healthcare spending is wasteful or inefficient. While interventions can reduce wasteful spending, they note that waste cannot be wholly eliminated. An example is given here in this sub-bullet of, at the national level, they identified 102 to 166 billion in estimated waste due to failures of care delivery. And then about 44 to 97 billion could be reduced through effective interventions. The waste domain of pricing failures in particular has driven commercial market spending growth. We give some examples in the sub-bullets. For example, in a 2019 research study found that hospital prices for routine services, joint replacements, and MRI scans varied by a factor of more than 5 within major U.S. cities. Just as Michael covered earlier, in cost driver analyses performed by other states with spending target programs, price growth has consistently been the reason for high commercial spending growth. And now I'll transition to OCA's recommendation for the healthcare spending target. CJ just covered this slide, but just kind of want to another reminder that this is what we're presenting today is the beginning of this process. A vote would occur later in the spring. We'll be sharing the input that you all provide today to the board tomorrow, and you'll have an opportunity to discuss our recommendation. So OCA recommends the adoption of a 3% statewide per capita healthcare spending target for 2025 through 2029. This is based on the average annual rate of change in historical median household income over the 20-year period from 2002 through 2022. I'll walk through the supporting rationale for our recommendation. I'd ask that you hold your questions until I go through the full proposal. There are several reasons for tying the target to historical median household income growth. First, basing the target on this measure adheres to the statute's requirement to promote the goal of improved consumer affordability. This is also in alignment with the board's preference for using a consumer-centric economic indicator. Most importantly, tying to historical median household income growth signals that healthcare spending should not grow faster than the income of California's families. Additional rationale for our spending recommendation is that a single indicator is simpler to publicly communicate and understand, rather than a blended indicator approach. The recommendation is also to use a flat average annual percent change in median household income growth to avoid concerns about decisions on how to weight or adjust distinct time periods within the 20 years. Lastly, a 20-year average of historical data reflects long-term patterns and does not rely upon uncertain forecasting. OCA recommends not applying adjustments to the target. With respect to adjustments, OCA examined both population-based measures and technology-related factors. In October, with the board, we discussed adjustments based on population-based measures for age, sex, disability status, and prevalence of chronic conditions. We found that the adjustments appear to be small and correlated with one another and potentially other economic indicators. There is also limited data available to forecast the impact of some population-based indicators on future spending growth. For technology-related factors, OCA would need to predict the net impact of new technology on healthcare spending in advance of market entry, because the target is set in advance of the performance year. Further, we talked about this just a few moments ago. Broadly applying a technology adjustment would also assume equal rates of adoption across all healthcare entities, which is not consistent with practice and the literature. Rather than making prospective adjustments for uncertain technology impacts, other states provide context for drivers of spending when reporting unusual or infrequent events that have an outsized impact on spending growth. For example, as previously mentioned, the introduction of Sovaldi to treat hepatitis C, that caused many healthcare entities in Massachusetts to exceed the target, and Massachusetts provided that context in their public reporting. Likewise, OCA would also take into consideration specific facts, such as market-wide events, when determining whether enforcement is appropriate for entities that exceed the target. I'll now cover OCA's recommendations on revisiting the target. Under the statute, the board has the authority to revisit the target, to update it periodically, and consider any relevant adjustment factors. OCA's recommendation is for the board to consider changes to the target in the event of extraordinary circumstances, which include highly significant changes in the economy or the healthcare system. OCA recommends that the board meet annually to consider whether any needed updates should occur for the target, including adjustments for unforeseen circumstances. This, wraps up my overview of our recommendation, and I'll turn it back over to the facilitator for questions and discussion.
All right, questions from the committee? We'll start with Andrew.
I don't know why I always go first. It's more of a process question, right? The statute requires a labor adjustment. So I guess, can you speak on how that's going to work? Thinking more specifically on, there are two components, right? You have the wage rate itself, and then you have FTE count. So I guess, if you can, speak to how, these targets would be adjusted for labor. And then I guess I'll probably rehash some of my comments from the prior committee on, the target being based off of 20 years of history with the Great Recession in the middle, based off of, near zero interest rates for a good chunk of that time. It's just really not the world we're living in right now. So it's our job is to forecast, right? You set a target for the future, and the historical just really, at least over the 20-year period, does not seem like a, representative of what the future is going to look like. And then, as an actuary, the age gender thing, I'm like, no, we have to acknowledge that people are getting older and it's worth something. I realized that last time, there was a range of estimates from 0.1 to 0.6. Those points, they matter, right? And kind of really don't believe the 0.1. It just doesn't pass the smell test. Aging is probably closer half a point to a point. So I guess you wanted to bring those, multiple questions. But really, the important thing is really trying to understand the labor adjustment. How does that work?
Yeah, the statute does include an organized labor cost adjustment. It requires healthcare entities, such as providers and fully integrated delivery systems to provide a showing to the office that organized labor costs grew faster than the rate of the target, and that impacts their ability to meet the target. OCA is still working on the process for how would this all work in terms of providing the showing to the office, what types of data would be required. So that's something coming in the near future.
And Rochelle, it's prospective, right? It's not a retrospective adjustment. I'm just trying to understand prospective versus retrospective.
It would depend on when the labor agreement is reached. It could be, depends on the timing of that, whether it affects kind of the current year performance or, for the future target for next year. So we'll work out those details on kind of when the adjustment would be made.
Sarah and then Stacy.
My humble opinion is that it makes sense to, well, I can't imagine the spending target being any higher than 3%, given that I think healthcare affordability has just gotten worse. People already can't afford healthcare, and we have to strike some sort of balance between, people don't get healthcare if they can't afford it. So if we allow spending to raise higher, what is the point if people can't get the health care they need?
Stacy and then Ken.
Thank you, Vishal, for going behind the reasoning behind the target. I think that's always helpful. I do have some concerns about the target and being tied to the average median household income over that 20-year period, which is a long time. It's not tied to inflation or other cost trends or uncontrollable expenses that we're seeing. And it doesn't take into account the starting point. So we're in a capitated model, very low trends every year. So we have less of an opportunity for savings than others. And the waste that we can squeeze out, we've been doing that over the last 35 years. Some of the inflationary or regulatory changes that we're facing that we know will increase our costs is significant staffing increases, which is wonderful. We have SB 525 minimum wage that we're facing over the next 3 years, which will significantly impact the medical group side more than hospital because we have a lot of lower income wage earners. We have physician shortages as well as staffing shortages. We're still 21% understaffed. And we are losing physicians that are retiring or significant hiring bonuses that we're all facing. The pharma costs, I think we talked about the specialty pharmacy. In addition to specialty pharmacy, we have significant pharmaceuticals in our clinic sites, as well as the retail pharmacy that would be included in the total cost of care. We have electronic health record changes. We have significant technology that is very expensive and increasing up with radiology equipment costs, as well as look at COVID, all of us having to buy new laboratory equipment just to be able to do COVID testing on a dime. We have more complicated patients, a higher rate of obesity, and then we have changes in our other payer mix. Medicare Advantage, with a change in risk-based reimbursement, is changing from V24 to V28. That's going to be a significant reduction in our revenue, as well as the STAR for Medicare Advantage that'll have an impact on revenue. So we have, my concern is it's not tied to what's out there that will impact us. I get our controllable expense, and we're, have to be accountable to that. But those that are happening by legislation or regulatory or requirements, we don't have control over that. And I just don't want our access to be compromised for Californians. Thank you.
Thank you, Ken, Joan, and then Barry.
Yeah, I have a question. You said earlier that whether organized labor agreements were pushing the cost of wages up, but I'm not sure I understand what the correlation is going to be, as Stacy just mentioned, for the minimum wage increases that aren't necessarily provided for through collective bargaining, but I'm sure the agreements will be working towards catching up in a lot of cases.
Yeah, thanks, Ken. I just didn't catch the question.
I'm just wondering, is it just purely focusing on the increase in collective bargaining agreement wages? When they're impacted, they're going to be impacted by mandatory statutory wage increases.
Yeah, the statute includes an adjustment for organized labor costs that's kind of built in, where it does, after the target's been set, there's a process where we could adjust the target for a provider. So minimum wage, if it's not counted under the minimum wage, would be kind of a separate issue. There's a lot of factors affecting healthcare entities, and if a healthcare entity would exceed the target because of minimum wage, that would be something we would look at on the back end, and then that would be a consideration as OCA's enforcement approach to determine whether that would be appropriate. And we're aware of kind of the mandates that are happening on healthcare entities, and then also Medi-Cal, there's increased spending due to expansions going on. So we would be able to differentiate between the different factors affecting healthcare entities.
Joan, Barry, and then Ivana.
So I was very happy to see the 3% recommendation. That is a great starting place, and I'm very happy that's where that's the framework the board will be starting from tomorrow. Also really appreciate that it is tied to the consumer experience, that we are starting from household income. I feel like that is an incredibly appropriate measure to be starting from, because really we are here to improve the experience for consumers and for purchasers. And so just starting off with that as excellent. I would recommend that the board look at the length. The 5-year initial window feels long before we get to entity and sector specific targets. And this goes to one of Stacy's points earlier about different entities are starting from different cost bases. There are some high cost outliers that we know are out there, and then there are others that have been struggling with a much lower cost starting place. And so for my money, I'd rather get to sector specific and entity specific targets a little bit faster.
Thank you. Barry and then Ivana.
Yeah, I just wanted to dissect a little bit more two of Andrew's comments. One on the organized labor consideration, and I think I mentioned this at a prior meeting, but I too have been a professor and think that repetition is good. I assume that does not only apply to entities with organized labor contracts, because as I pointed out, we all pull from the same market of employees. So if you're in the neighborhood with all due respect, a Kaiser facility, and they go through an organized labor negotiation, you have to shadow price, or you simply will not have employees, even if you don't have an organized labor contract. So I think it needs to be considered, same issue, but considered without regard to whether or not there's an organized labor contract. Second, in terms of what the target cap is based upon, using a 20-year look back at household income that, as Andrew suggested, included a Great Recession, seems to be somewhat unrealistic, particularly if you look at, I think, a more realistic time frame of 2013 to 2022 in California data, in which case the median household income grew by 4.1%.
Thank you. Ivana?
The talk about the increasing wages makes me feel a little bit like what Sarah talked about before, about not knowing the impact of, more technology or more expensive technology, because I think you can make the argument that higher wages means workers become more productive. There's less turnover, there's less recruiting costs. They give better care, so patients are healthier, and that drives down costs. So I'm not willing to just concede that, if wage rates go up, that automatically costs are going to go up in equal proportion. And I think we have to actually see what the impact is. I also think that I agree with what some others have said, that I like the 3%, spending targets. And, I feel like there's already gaming going on in the system, right? I feel like there's already providers that, in anticipation of knowing that there's going to be these caps, are already raising their rates now, because this is like the last window that they can do it without anybody, noticing or saying anything about it. So, I feel like keeping it really simple. This is an industry with a lot of really smart people who are really wily, and if we give them ways to make adjustments, it's just is going to blow those doors open, and it's going to defeat the purpose. And as happy as I was to see 5 years at 3%, I just want to say that this is still not going to take care of a lot of the problem. I mean, again, I'll just talk about Monterey. Hospitals are charging 500% of Medicare. They're already, crowing in the press about, oh, well, we've only given 5% increases in the last couple of years, conveniently omitting to, sort of admit to the fact that they're already, paying 500, we're paying 500% of Medicare, over 500% of Medicare for inpatient costs, right? So, I think that as good as this is, it's still not going to take care of the problem, and we need to really keep, people's eyes on the prize so that the industry really goes out and realizes that we're serious and has to look for those efficiencies that we're going to hear more about, and has to get rid of the waste, because we just can't, as other people have said, we can't afford it anymore.
Thank you. Carolyn and then Carmen.
Thank you. First of all, kudos, Ivana. I 100% am in alignment with what's being said at this table. I want to swing back to Sarah and Joan's thoughts, mainly because I sit in that direct service human perspective. And I'm right now working with a professional family, a registered nurse who just retired, her 72-year-old husband, who are care providing for their 52-year-old daughter with severe multiple sclerosis, who fell outside in the yard and stayed out in the sun for 6 hours before an ambulance could get to her in a far rural North County. Okay? This is a couple where I've come to realize they are literally committing fraud in order to be able to provide care for their daughter, who's now a disabled teacher. So these are not individuals on the street. These are your average working Americans. And when we're looking at that kind of a story, and this is repeatedly happening in our region where lack of primary care providers are available, where lack of ambulance services are available, when our federally health qualified clinics are shutting down, where we have 5 of the top fastest population loss counties in the region. Healthcare is deplorable. The cost of healthcare is even worse because the farther out you go from the masses, the more it costs. So, you know, it's hard for me to sit at the table and listen to some of what we're talking about when I walk away on a lunch break and find out, is that family okay for today? Are they okay for today? So I do think it's important to bring that real human perspective back to this table. And I will do that repeatedly because that's my day. That's my realm. I'm also happy to see the 3%. There's no easy answers here. But you know what? Any one of us at this table could be that family.
Thank you, Carmen.
Thanks, and I want to thank you for bringing really good perspective up here, and I kind of trying to tie it back to, you know, what Joan, and even though we're saying it's really important for us to get back to the how things are being spent in the system, and you know, as Michael was mentioning earlier in the previous agenda item, you know, it's really important for us to figure out not just these larger statewide spend numbers and targets, but trying to figure out like why are costs this high? Is it actually going to the patients that Carolyn was going to, or is it going towards something else? And I think that's really important that we, you know, we think about this when we're looking at initially at the statewide spending targets. 3% is great. And, you know, I think when we're talking about labor adjustments, wage increases, things like that, this is why we have the workforce stability standards that we're looking at later, so that we can figure out whether or not healthcare workers are actually being paid adequately and compensated adequately and protected appropriately in their workplaces, so that we can actually provide the care at while supporting healthcare workers and the economy of folks who actually care for folks, but then also making sure that we're not overspending on things that are, you know, what some of us would call fat, and so that we can identify what the fat is, and so that we can say, well, actually, healthcare providers should not be spending on that fat. And I don't think that healthcare worker wages or compensation are part of that fat. And I think, you know, we need to get to that point. And I think this is a great starting point to say this is what we're going to look at as a state overall. And then let's go look more specifically at what each healthcare provider is spending, so that we can see, you know, I think we've talked about this before with non-unionized workforces. We can't just be giving healthcare providers increases if, you know, on the assumption that they'll increase workers' wages. It's a runaround to you know, preventing organization through labor organizing of healthcare workers. And I think we need to be very cautious about doing too much now when we're looking at the state as a whole.
Thank you. Our next comment is from a committee member attending virtually. As a reminder, remote members should have their cameras on unless appearance is technologically impracticable. If there are internet connectivity issues, members should announce the reason for non-appearance when they turn off their camera. We note that Adam Daugherty is participating remotely, but off camera due to technical limitations at his location. Adam, do you have a comment?
Hi, yes, thank you. And I apologize. I'm in a hospital facility without access to video. I would like to further emphasize the importance of getting to those sector level targets sooner rather than later. I also have concerns with the 5-year time frame, and I'd encourage us to get to those sectors early. I can tell you in emergency departments across the state, we're seeing extremely high volumes of very high acuity patients. And, as a result, our costs are skyrocketing. And that's a direct result of, numerous factors, including failure of network adequacy of, payers. Patients can't get to their specialists. Care is delayed. Diagnoses are delayed. And we have to deal with those failures and those complexities that come from that high cost of drugs, medication noncompliance, mental health, substance abuse, comorbidities all contribute to that. And we have to do the best we can to deal with those things. So, I think it's important to understand that where the costs are realized are not where they are created. So I would continue to urge caution where we can, of course, only affect what we can affect, but it should not result in making my job harder or, attempting to reduce costs by restricting things I have access to because of outside forces. So, again, encouraging us to get to those sector targets while realizing that just because we can push down on something from our purview does not mean that should be the way to reduce costs ultimately.
Thank you. Sarah, Anthony, David, Tam.
I had a question, and I'm not sure if I'm getting too much into the weeds or if this is even a coherent question, but like in terms of labor costs, when there's increases, but they're lower than inflation, does that somehow, is that taken into account? Like, let's say a labor deal is struck, but overall the raises that these workers are getting are less than inflation, if that makes sense.
Yeah, thanks, Sarah. Under the statute, it contemplates situations where organized labor cost increases. There would be a process for those providers to come, or other parties to the agreement could come forward and request an adjustment. But as far as so it's kind of, if it's higher, but your question about lower, yeah, we wouldn't necessarily know about that right away. So there wouldn't necessarily be an adjustment for that. Yeah.
Thank you, Anthony.
Yeah, so I actually, in the spirit of Adam's comment, I think that is the hope of this holistic approach, is that we are in fact looking at the whole of the system and trying to identify if there are costs, how do we deal with them, and if that requires upstream strategies or others, or identifications of market failures and fixing of those market failures or others. That's the hope of this process, rather than just allowing the costs to grow and then allowing consumers, employers, taxpayers to foot the bill afterwards. And so I think that's so we need to have a goal. If we're never going to meet a goal we never set. And I appreciate the thought that has been put into this. We agree with the notion of wage and income growth, that it makes sense to, when talking to consumers who frankly would want a cut or at least a freeze, to say, well, at least it's not that the healthcare costs, we're not going to promise you anything more than that costs just are not outpacing what your wages and income are going to be increasing. And I think that's a reasonable thing. I also appreciate in the appendix, slide 140, I don't know if you want to pull it up or just to describe it, but you compare this to what other states are doing, and where most other states have set a 3% or lower target going forward. So this is aligned with where our other states that are engaged in this process are doing, including our two compatriots in Oregon and Washington. Normally California would like to lead, but I think we should be at least aligned with where our West Coast and other states are moving with regard to it. You put it all the way back at 140. So I wanted to sort of point it out as just a useful comparison, because it would be hard to tell Californians that they should have a higher rate than other states, and so I think that's appropriate. But I do take seriously the question of, our different parts, Barry's comment that, our different parts of our state starting at different base levels. Like the Bay Area is starting from a very different base level than the Central Valley, just from, we contain multitudes. We have both if they were different states, they would be the richest and poorest states in the union. So like we need to take, have those considerations. And so we should have this set the statewide target and hopefully move more quickly on taking into consideration some of the diversity within our state with regard to sector and region. I'd also say that I think the more fun story is and the more important story is not just setting the target, but in order for them to be real, rather than just having a situation where the entire industry doesn't meet the goal, is to have the real work of how do we get to that goal and how do we identify whether it's the market failures in some places, the lack of upstream intervention, and others that Adam was talking about, others, so that we can actually meet these goals. Because what I don't think is sustainable is just to have these problems, not having them acknowledged, and then just having consumers and taxpayers fit the bill at the end. Like the promise of this process is the identification and working to get to meet the goal. But I do think that the 3% goal is a good, aligned with other states, and I appreciate it.
Thank you, David, Tam, and then Karen.
Yeah, thank you for this work. I want to make a few points. First of all, in my opinion, taking the 20-year household income, which by the way had historically low interest rates and inflation during that time frame, has nothing to do with medical cost inflation and nothing to do with the input costs of healthcare. And so I'm fundamentally uncomfortable with taking, it feels like apples and oranges. Household income historically has nothing to do with future medical costs. And I think fundamentally, for this process to be effective, the targets have to be believable, that they make sense, and developing a target from something that has nothing to do with future medical costs, to me, undermines that issue. Second of all, I'm worried about unintended consequences. So for example, the story about the rural access to healthcare might actually be the case that reimbursement in that market might be too low to attract enough providers to serve that population. So it may not be, inevitably there's a trade-off between access and cost, and every market is different, but I think we've really got to be careful here that we will see unintended consequences. Another example is there's a revolution in cancer care today, where there are very expensive treatments that can treat cancers that historically could not be cured, blood cancers, for example. And I worry about setting a target which will result in reduced access to consumers of those kinds of technologies. I would strongly urge that the way to have more credibility will be to move faster to sector targets. In particular, I think it doesn't make sense to set the same trend target to a high-cost provider who's maybe been exploiting a marketplace position versus a low-cost provider who's been competing effectively and providing value. It just doesn't make sense to set the same targets to both of those scenarios. And so I strongly urge that setting sector-based targets much earlier will be important for credibility. And I would reconsider whether household income is really the right starting point. I think it should be adjusted in some way for medical cost inflation. For example, meeting the state minimum wage requirements in the legislation was passed last year is a factor that healthcare providers must pay. There's no choice about it because it's the law. We should be adjusting for things like that and recognize that they inevitably drive up costs.
Thank you, Buddy Tam, Karen, and then we will move to public comment.
Hi, good morning, and thank you, Tam Ma with UC Health. And I very much wanted to start by appreciating OCA for keeping us grounded in the purpose of this effort, which is to improve affordability, for consumers and patients. And what we're seeing across all of our UC academic medical centers is that patients are showing up sicker with much more complex health needs, and we know that this is attributed to the impacts of the pandemic, but we also know that our patients are getting older, right, as well. And we do expect, folks to continue showing up, patients with higher acuity to continue showing up in, the coming years. And we're in a place right now where our hospitals are completely full and, trying to treat as many people as we can and also finding ways to expand capacity so that patients aren't waiting so long or, turned away for services. So I think in the context of the proposed target, we are concerned about, how it'll impact our efforts to improve, access and continue providing, quality patient care. And so there's a lot of, questions and issues that OCA is still working through that provides, the context for the targets, like in terms of like adjustments for risk and equity, figuring out how, this data and methodologies that we use to attribute costs to providers and measure performance. And I wanted to bring up, one policy choice, like kind of state policy change that hasn't been raised yet, which is around implementation of CalAIM in Medi-Cal, where, Medi-Cal is increasingly addressing a broader spectrum, of patient needs and adding new benefits and services. And so as a state, and as a public health system, we've agree that these are important policy decisions to advance health outcomes for patients who have the highest need, highest risk, folks who have been historically marginalized in the healthcare system. And we, share the goals that these investments in Medi-Cal and CalAIM will ultimately reduce costs, right, and improve outcomes. But they do require, providers and, and the public health systems to make, significant investments to grow the infrastructure and services and to be able to support, the, increased, utilization and, the higher level of coordination of services that are needed. And so we, think that the target really needs to consider some of these underlying, costs and needs in the near future, in the development of the methodology. And so that, we would be able to help, and continue partnering with the state to implement, these important policy objectives.
Thank you. We'll move to Karen and then public comment.
Great, thanks so much, and I'll keep it short because I want to get to public comment, but I just want to say I appreciate the approach that OCA has taken to base the target on median household income, and I think stay true to the vision and values of this work. And I frankly think 3% is the least we can do because looking at the data, 3% probably won't make care meaningfully more affordable. It will simply keep it from becoming even more unaffordable for consumers. And I suspect there will be concerns raised about reduced access, but I appreciate you sharing the data on equity because access is very inequitable today. We have a real healthcare system of the haves and the have-nots, right? And the primary factor that drives that inequitable access is cost. And I also want to make a note, I really do support the recommendation not to make the population adjustments at this time. Perhaps in the future, we can look at downward adjustments in order to push the healthcare system to innovate and provide better care, particularly for older Californians, where I feel like there's a real opportunity for us to do better by them at a much lower cost. Because I do think the important piece here is really improving the system, not only reducing the cost. And today, I think we know we have people dying from painful and preventable conditions because the incentives in the system are wrong. And we are trying to move away from a system where the primary motivation is profit, not only, again, to lower costs, but also to provide good care for everyone. So I appreciate the work of the office here and look forward to the board's discussion.
Thank you. We'll now move to public comment. To ensure equitable access, we will alternate between members of the public present in the room and those virtual. Those in the room may line up at the podium. Those attending virtually, please raise your hand. Please keep your comments to 2 minutes or less if possible, so we can hear from as many members of the public as we can. I will start with the room, looking to individuals at the podium.
Ben Johnson with the California Hospital Association. We are concerned that OCA staff's final proposed spending target misses the mark. Specifically, we don't think it strikes a balance between promoting affordability and maintaining access to high quality and equitable care. As a sudden 40% drop in healthcare spending growth really is not achievable without serious negative consequences for patients. We are concerned that the methodology is arbitrary and ignores external factors that influence healthcare costs, such as inflation and California's aging population. For example, the proposed target is 0.5% lower than what the state's independent legislative analyst's office projects economy-wide inflation to be over the next several years. And this would leave healthcare entities unable to afford to hire their workers and the medical supplies that they need to save patients' lives. It also ignores the significant impact of aging on healthcare spending in California, which data from the Department of Finance and the Centers for Medicare and Medicaid show will amount to about a 0.7% increase every year over the next several years, or about $3.5 billion each year. OCA staff rejected such an adjustment from their methodology by saying this adjustment would be negligible, but we do not think it would be for the aging population. And then finally, based on analysis from the California Healthcare Foundation, we find that OCA staff's recommended target is actually the lowest in the country, in no small part because there is no inclusion of a ramp down and phase-in period. And so while other states typically set their targets at about a percentage point in addition to GDP, California is proposing to set a target that is 2 percentage points less than our historical GDP growth. And while other states were dealing with inflation of less than 2% when they set their targets, the OCA's proposal is coming when California has experienced a target inflation in excess of 4%. So, and then finally, we are concerned that the proposal is really devoid of, I think, an adequate analysis of what the impact on the healthcare entities as well as patient care would be in California. So to fulfill its statutory mandate, we believe OCA needs to present a sounder rationale for why the target meets the multiple objectives present in state law, including by promoting affordability, but while supporting the ability of California's healthcare system to improve access to world-leading and life-saving care. Thank you.
Thank you. Looking virtually for hands raised. If you'd like to make a comment, please raise your hand and we will unmute you. Noting for the record, we have roughly 65, 70 attendees online. Seeing no hands raised at this time. Looking back to the room, if you'd like to make a comment, please step to the podium. Seeing no one at this time, stepping to the podium. And seeing no hands raised. That concludes public comment on this item. At this time, it's 11:56. We will break for a 1-hour lunch. We will resume at 12:56 because we have a hard start of 1 p.m. We'd like to start right on time for our presenters. All right. Thank you for being back on time. We will now do our afternoon roll call. Joan Allen?
Present.
Barry Arbuckle?
Present.
Elizar Joyan? Stephanie Klein? Carmen Comsty? Adam Doherty? Parker Duncan Diaz,
Present.
Hector Flores, Sarah Gavin,
Present. Present.
Stacy, thank you, Sarah noted. Stacy Hratas,
Present.
David Joyner,
Present.
Ivana Krasinovich,
Present.
Tam Ma, Carolyn Nava,
Present.
Mike O'Day, Janice O'Malley, Sumana Reddy,
Present.
Yolanda Richardson, Karen Savage Sangwan,
Present.
Andrew C., Sarah Sorokin,
Present.
Ken Stewart,
Present.
Suzanne Usage, Yvonne Wagner, Renee Williams, Anthony Wright,
Good afternoon.
Abby Yount. All right, attendees noted for the record. We will now move to agenda item 5. Margaretta Brandt will introduce us.
Good afternoon, Margaret Brandt, Assistant Deputy Director for Health System Performance. Today, I'm excited to share with you an initiative that OCA has been working on to identify and share examples of cost-reducing strategies to complement the spending growth targets. So the goal of this project, if we can go to the next slide, is to highlight examples of successful cost-reducing strategies that also maintain or improve quality. And OCA is working with health plans, hospitals, and physician organizations to highlight examples of cost-reducing strategies that have demonstrated results in their organizations.
And when you come to a categorization of emotions with an
Okay, are we all set? Or can we go jump to the next slide, please? So thank you. These strategies can be a resource to support healthcare entities in meeting OCA's spending targets. And to start this project, we spoke with industry associations, quality improvement collaboratives, and others to understand their approach to cost-reducing strategies and seek introductions to healthcare entities who are implementing successful strategies. So we interviewed healthcare entities across California to identify strategies that reduce costs and are sustainable for the entity to implement and maintain. And from these interviews, we are working with several organizations to develop a summary of their strategy to share through a new HCI webpage. And then OCA wanted to note here that OCA did not independently verify information about the strategies and results provided by healthcare entities, and we're not endorsing any specific entity or strategy. These are intended to be helpful examples of cost-reducing strategies that can be a resource to others. So today, 2 organizations, Anthem Blue Cross and Sharp Steely, will be sharing an example of a cost-reducing strategy within their organization. And before I turn it over to the Anthem Blue Cross team, I'd like to announce that OCA is seeking additional examples of cost-reducing strategies to support this project. So we could go, thank you. So these examples might include a program that addresses a specific population, implementation of best practices for more efficient resource use, or an effort to increase care coordination. And with these examples, we're interested in the following. So a description of the project or the strategy, the purpose or rationale for implementing the strategy, results that demonstrate how the strategy reduced cost and improved or maintained quality of care, and any barriers or challenges to the strategy itself. So listed on the slide, you'll note our general inbox. If you would like to propose a cost-reducing strategy for consideration, we ask that you share this information with us and we'll review and follow up to learn more. So now I'd like to introduce Mohit Ghosh, State Affairs, and Dr. Tiffany Inglis, National Medical Director, Women and Children's Health from Anthem Blue Cross, to share their cost-reducing strategy on improving maternity care. So we'll have Anthem present, and then we'll have a few minutes for questions after their presentation. So Mohit.
Thank you, Margareta. Hi, everyone. Mohit Ghosh with Anthem. I've worked with several of you in the room over the years, and definitely having as much work as I can with Vishal and team at OCA. So thank you for having us. For those of you who don't know us, we've been in the state for more than 80 years. We've provided coverage in all market spaces in the state of California. We provide coverage for more than 9 million people in the state, including about 1.5 million people in Medicaid, or what we call Medi-Cal. As part of that work, we've evolved over time with the state, with the needs of the populations that we serve. And what you're going to see here today from Dr. Inglis, and I see her on the screen, so I know she's dialed in. That's wonderful. Hi, Tiffany. Is something that we kind of workshopped in California, whether it was the doula benefit that we started very early on that, J.C. Cooper over at DHCS actually credited with the creation or some of that research that we were able to do, some of the outcomes that we were able to generate around the doula benefit that we were providing led to the benefit actually being included in DHCS's Medi-Cal coverage. And, we've been now in implementation for about a year and a little bit. It hasn't been easy. There's a lot of issues that we continue and lots of challenges that we face with that, but it doesn't take away from our focus and commitment to improving maternity, both pre and postpartum care that we are able to cover and encourage others to provide in the state of California. So the example that you're seeing here today is something that we built internally. We floated out. We saw how it worked. We retooled it. And then we really let the evidence drive the coverage. I think that's very, very important for people to understand, is that in a world of limited resources, in a world of limited healthcare dollars, we want to pay for what works. We want to pay for more of what works, because that's what's going to drive quality. That's what's going to drive equity, and that's what's going to ultimately drive us to a better system of population-based healthcare. So with that, I want to introduce Dr. Tiffany Inglis. She is our national medical director for Elevance Health, which is our parent company. We changed our national name about a year and a half ago. We are very much Anthem Blue Cross in the state of California, and very proud to be so in other states as well. But Tiffany leads our work for women and children's health. And this program grew in her shop, so she gets a lot of credit for actually bringing it all together. So Tiffany, without further ado, hand off to you. I'm here for questions, policy, etc. Tiffany's going to run the data. Thank you.
Sounds great. Thank you, Mohit. Can you all hear me okay? Make sure you can hear me. Take it. Yes, I hope so.
Yes, we can.
Okay. All right. Thanks for having me. Just a brief, I am a OBGYN by training. Mohit has given me more credit than I deserve. It's an amazing team of people really focused on women's and children's health. About 4 years ago, we really committed to a better understanding of what drives impact, what drives value, and what drives change, and what can impact a pregnant person's journey. Women make about 80% of the healthcare decisions for their family. They are the key healthcare drivers for healthy pregnancies, healthy children, and healthy families. And so we really wanted to dig deeper into that. And to his point, what we did was we sort of looked at what we were doing and really did deep dives into when and how and where can we do better, and when and how and where, when we do better, does that really drive change? And so these are some of those programs that we found that have really increased impact for our members and our providers. And so we can go to the next slide. This is sort of an executive summary view of those. And I'm going to start with 2 because he already mentioned the doula work. And I just want to build on what he was saying. We very early on had a few states, and California leading that very much looked to implementing doulas. Doulas are non-clinical providers that help support members through their pregnancy journey, to really understand how and where and when do doulas impact our outcomes. I think the other really big important piece to doulas that we found is that they significantly improve maternity outcomes, lower risk of low birth weight, lower risk of C-sections, but they also significantly reduce the lower incidence of postpartum anxiety and depression, and significantly do that. And they also can often work very, very well for women who are at risk of having healthcare disparities due to race and other factors that we see that are often very hard. Those differences are very hard to change. And what we see is that doulas do that. So we've really committed to working to not only grow that program in California and grow the impact, but also we've done a lot of work to increase access to doulas. We've done a lot of work to train doulas and to work with our partners in this space to ensure that we're training more and more certified doulas to make sure that we can get access. Because the other issue is that there aren't a lot of them. And so really also they're not used to working with healthcare providers. So our practice consultants, which is box one, they're clinical folks who work as a provider facing entity, and they actually were a big part of the doula work as well, so that they could help to break down the barriers between delivery providers, OBGYNs and midwives and doulas, and help make sure that we can tell the providers the why behind why we believe that doulas should be a bigger part of member care. Those practice liaisons, or clinical practice consultants, as we call them, they have more than just that role, but they were a big part of that. Up to the top box, this role is a very unique role that we have really seen a huge value. Basically, our practice consultants are clinicians. They're nurses who worked in the field. They worked on labor and delivery. They worked in postpartum. They worked in office settings that were tied to women's health. And they now work at Elevance and California's Anthem plan, and they basically facilitate providers. They are provider facing, and they work with providers to understand how to help improve and close care gaps, how to better understand their data and reporting, how to help providers when they have a problem. When they're not getting an answer, they are their first line. They're the first line that those providers have. They have a number straight to a person, an email straight to a person to say, I need help. Or, you know, Mohit is a provider in California and he needs a patient to get something, and that patient's struggling. They are also the first line for that. They sit within the state. They are directly linked to the state, to that plan that's in the state, and they help support those members. They've seen a significant increase in their ability to impact providers. We've grown that program significantly. We'll see in a later slide, they have driven significant value across reducing poor outcomes, which leads to a cost savings in that space. The other thing that we did in the last year or so is, as we were looking at especially some of the other issues with health equity and disparities in this space, we know now that postpartum, over 50% of women die in the postpartum timeframe who die from dual pregnancy related cause. And we know that the number one killer as of 2022 became behavioral health causes for all women other than Black women. For Black women, it remains cardiovascular causes of death. That was the number one killer for all prior to recent change, but number two killer for Black women's behavioral health. So what we did was we went and we actually shared this with ACOG, but we created collaterals for the providers to have to screen women at risk of cardiovascular behavioral health causes of morbidity or mortality in the postpartum space. Our practice consultants shared that with those providers, and those providers had a tool that they could use to then screen members quickly, easily, and help members get to care earlier. So really the drive there was to try to prevent those really catastrophic poor outcomes, identify women in need earlier and get them to earlier care and prevent those poor outcomes. The other thing that we've been really focused on is we've created a digital solution that is driven by predictive analytics to help members to deeper content. All members get content. Those members with significant indicators for poor outcome get a deeper level of content, a higher risk touch by personalized nursing, so that we can really drive that personalized experience to nurses that they are actually receive a bio about and understand that they are a real person, right? And that they actually have a lot of probably connection that they can find, and really help them to find care, find earlier care. And we also see earlier care, but it's better care. I think we can go to the next slide. And some of this is that doula. This is the data. So this is the true data behind the doulas. This is a study. This was actually, the study was published in The Lancet, and then we actually have a public policy paper that Elevance did as well, based on the data that much of it came from California data. It's helped us to drive this landscape. It's helped us to drive access. It's helped us to drive funding more access, but also increasing benefit coverage to make sure that more and more people have access. So you see reduced preterm birth, reduced cesarean section rates, reduced lower birth weight rate, reduced hospital admissions during pregnancy, reduced ER usage in the postpartum period, and reduced NICU admissions. The only thing that's not on this infographic and this visual is there's also an associated 59% reduction in postpartum depression and anxiety. So that's a significant reduction, all just by adding this social doula support structure. All of these doulas were community-based doulas, so all of these doulas came from the community, came from the environment that these members were living in and experiencing their care in. And when you talk to the members, you know, overwhelmingly what we hear is, I finally felt valued, heard, and understood in my care. And this really helped me to find my voice, which I think we hear so often from women, especially women who are at risk of a disparity, telling us over and over again that that's what they didn't feel. So this was a huge driver in outcomes and therefore spend. And then we can go to the next slide. This one is a deeper dive. Oh, one in the middle. These are actual live links. You can go into them. These are external publications that we have. The one in the middle is the doula study that I referenced as an overview of the doula study. There's some other doula overviews there. And then there's also some information about our provider enablement, which is our practice consultants. So these are pieces of literature that if anyone has more interest, they're welcome to look here, or Mohit and I are happy to answer any questions. But these are external pieces of literature that we've shared to try to continue to carry that message of why we've invested in these, and we feel these are so important to make sure that people have access to. And then we can go to the next slide. This is just describing what that practice consultant is. I've spoken to it quite a bit before. I won't go into it. The bottom, we have lots of provider testimonials. We have amazing provider feedback on this program. They love this program. They love having this program. They're very connected to their support personnel. And having this support person really be the middle ground between the health plan and the provider has really helped us to have a much better communication path and to help us drive more change. The care delivery provider, that OBGYN, that midwife, is so vital in making sure that members get what they need. And we recognize that, and we really want to be able to support them in that space. So we can go to the next slide. This is the outcomes of that program. So kind of a busy slide, lots of numbers. I'll sort of describe it a bit. The links in here are, the one on the right is a live link. It's a story that Becker's did on the actual program. So, but basically the top line is just our value-based care program that we're still working to implement in California. But the practice consultants alone, when not attributed to any value-based care programming, we see a 2% reduction in birth cost savings. We see a 2% reduction in maternal first-year savings. We see a 4% reduction in babies' first-year savings. And that's all driven by a reduction in low birth weight, an increase in prenatal timeliness of care, a reduction in our C-section rates and things of that nature. So it's all driven by getting members to care earlier, getting them to quality care, and really helping the providers to have an easier path to deliver care. When we combine our practice consultants with providers who are in value-based programs, we see like that symbiotic relationship really grow and even drive this further. So that's what the bottom line is talking about, is when we see our practice consultants working with value-based providers, we really, really see that sort of, that's what we call the secret sauce, right? We see that increase in outcomes and improvement drive up. As part of our commitment to this work, we've added health equity measures into our value-based care programs, and we've also partnered with March of Dimes. And we did a full implicit bias training in 21, and then we did a second round of implicit bias training for our staff in 23. And we're actually training the top 500 by volume of our providers as well. So really a commitment to finding and helping members find a voice and really being a part of their care. I think that's the last slide, so I'm happy to take any questions after that. And Mohit, if I missed anything, please speak up for me.
Yeah, no, thank you, Tiffany. Very comprehensive. I think the numbers at the end really do say a lot. But one thing I wanted you to address is, practice transformation takes time and investment. And, we dealt with a number of challenges. The one that stands out to me is when you explained how we had to deal with maternity wards to allow doulas to actually be with the birthing mother, like at the ward, because they're not technically family. I mean, speak to some of those types of challenges really quick. I think the committee could use that thought process, because the investments and the time and the effort and the people really do matter in how these programs get built out.
Yeah, I think it's a really good call. I mean, you have to explain the why, and otherwise it's hard to change culture and behavior, right? And so I think what we really leaned into and what we found a lot of success with is when we went to our providers and used a member of our team that was trusted and really shared this information and the understanding of the why, it can break down some of those silos and barriers, right? I mean, if we're being honest, there are barriers between like the delivery care providers, the OBGYNs and midwives and the doulas and them, right? We see this all the time. I have frequent conversations bringing these groups together, and there's distrust, there's history, and there's discomfort with the whole process, right? Doulas have never worked in a health plan delivery system before. Like they're not used to the insurance process, right? So it's really been it's got to be somewhat of a labor of love because it's important. And I think that's what you hear from us is it is important. And when we take the time and we go and we say the why, we can see that we can break down some of those barriers. But to your point, it does take time. I mean, it does take really showing them and understanding and building that trust back to a place where we can get the commitment and the understanding that it doesn't work if they're just on the phone as well as it does when they're in the room. And so we really do want to make sure that we're supporting that. Now, if the phone is the only option, okay, but like let's try to find the maximum way that we can bring people in and really impact care. And it's so hard to change these maternity numbers. I mean, California, you guys have done a great job, right? There's so many quality things that have happened. And you guys are leaders in that space, but there's so much work to do. I always say we started at A and we have to get to Z, and we've got to have some stops along the way, but we just have to keep building on what works. And I think the other thing, Mohit, and I'm a little off track here, but like we continually keep looking, like we're refreshing all of our doula data right now to make sure that we're continually monitoring like what do we need to change to update and to continue to have the growth that we see and the process and the progress that we see. And that's another huge commitment, right? Because you do have to take time to like continually check yourself to make sure that you're updating where you need to be.
Yeah, and that's a great point. We're having to not only train people who are, if you say non-traditional medical providers today, or with the medicalization of social services, there's a number of items that come into play where you're literally teaching people how to do managed care. Now, luckily for us, we've had experience in that over 80 years in California. We've built systems with DHCS in the rural north and other places that now actually do operate even in Medi-Cal under managed care. We were there at the inception. But in understanding that and being able to not only teach billables, but also teach practice transformation or work collaboratively on practice transformation. Again, it all requires investment. And then ultimately, you see on the back end, once the systems are actually in place and working, you're able to then move forward with seeing some savings. But the biggest goal here is improving access, improving equity, making sure that mothers and babies are supported the right way. And that's what this program shows you.
Let's take comments and questions from the committee. So we've got Samana, Ken, and then Parker.
First of all, Dr. Inglis, and them, I mean, major congratulations for a program that as a family doctor who delivered babies and attended births for 17 years and was a huge doula supporter in my community, I know what the challenges were in bringing them into the labor room and in changing that culture. So I think it takes like a huge amount of your passion, you know, to create this kind of program. And you answered those questions about some of the structures. I'm assuming that these particular doulas were paid directly by Anthem, and I was very curious about the acceptance, you know, in hospitals. Also, it's fabulous that you were able to show these kinds of cost and data outcomes, and that's driving it is amazing. There's so much more that can be done with that relationship. I'm sure you're working with your doulas on vaccine acceptance.
Yes.
You know, these are some of the areas that I'm seeing our OBs not taking up in terms of COVID, now RSV. So it's major, but wonderful that the time has come. I personally had practically given up on the idea that doulas were going to be supported in the labor and delivery suite. So thank you.
Yeah, no, it's a great call out too. And those are good. I didn't speak to that, and you're right. Like there's a lot of the doulas have this natural ability to connect and get people to the things that they have available to them that they maybe don't realize or aren't sure, or not trusting with vaccine, transportation, food, all of that, right? And so really working with the doulas to understand what we offer too in that space so that they can be the voice of that. So you're right, that's not even captured here, and that's been a huge add. I would agree.
We have 5 minutes left on this item, so we'll go to Ken, Parker, and then Carolyn.
Yeah, hi. Question: has any attention been paid to preventing or eliminating elective C-sections?
Yeah, so we do a lot of work looking at C-sections. Obviously, like ACOG's guidance on elective C-sections, but is what it is, but we do a lot of work on understanding that. We break it down to those primary C-sections, or those, we call them actionable primary C-sections, right? So those ones that we know that rate varies from 7 to 70% depending on provider. So in our value-based care solutions, we have those metrics. Sometimes they like them, sometimes they don't. We do that with provider, we do it with professional level, and we have facility level, like C-section is one of those. But I would tell you, we also have done a lot of work understanding the drivers to C-section. And I think that sometimes can be more impactful. I'm a firm believer in what we've seen in some of our other data is in our programs where we have process measures and outcome measures, we see more impact. When you just focus on the outcome. So if I'm just focused on C-section, it's hard for me to tell you where and when maybe you could have changed that outcome. But if we're looking at process as we go, so age is a huge driver of C-section. Fertility treatments is a huge driver of C-section. Hypertension is, obesity is, some of these other things, and preterm birth actually is a huge driver for C-section. So if we can go back then and like sort of root cause their risk that they may have that's leading to there, and that's what we've done with some of the predictive analytics and the work in the digital solutions is like prioritizing those risks and getting those members to higher level touch. And then trying to hope that we can impact that C-section rate. I don't have to tell you all, C-section rate's a tough one to move, but we're sort of taking the approach of like, do the deep dive, understand what's driving it, and then act upon those things to help potentially reduce that number later. But I do think the process and the outcome measures have to be there to really get to that place.
Thank you, Parker, and then Carolyn.
Hi, I'm Parker Duncan Diaz, and I'm also a family doc, and I'm in the first 10 years and still delivering babies. I do it through an FQHC, so we have a unique structure of family docs and then family who are also C-section trained, fellowship trained. We deliver at a Sutter hospital, and so all of our population are Medi-Cal, and then particularly, as you probably know in California, ours are OB Medi-Cal, aka our patients don't have insurance otherwise. They only get insurance during they get temporary insurance to cover their OB period, and then it ends. Now, one of the other exciting things, as you probably heard in California, is that got extended to a year postpartum instead of the traditional 6 weeks, and that was very exciting. So if you had something to do with that, thank you. But we we have the partnership plan that is our regional Medi-Cal, and so they have rolled out this doula service as well. And this is as much a comment following up on Mohit's comment, things take time for change. So our partnership rolled this plan out and said, hey, doulas, you know, we're going to get covered. So I deal with an 85% Spanish speaking population. And in the entire county region of Sonoma County, there are 2 doulas available. We do over 700 deliveries a year, and neither one of them speaks a word of Spanish. So it's a great idea, and I'm behind it, and our group has been pushing for it, and yet, you know, a full year in, it's essentially totally unavailable to our population. So in that comment of great idea and let's keep going, there's a whole lot of steps to go.
You know, you are illustrating something that we're struggling with everywhere. It is the training, it is the credentialing, it is making sure that we are working with anybody who will actually work with us to improve the availability of doulas. So I'm not saying that we have a, you know, fully, you know, up and running, we've got doulas for every mom who wants them or every mother to be. But what's important is we've embarked on a journey. We're looking and tinkering with the process as we go so that the policy decisions that are made based on what we're being able to produce are meaningful, right? My biggest fear is that we make policy decisions that are not based in reality, and then we end up with policy that simply doesn't work in the medical marketplace. So that's how we're learning. And when we see something that works, that's why we're implementing. So, and we're going to keep doing it regardless of the challenges and barriers that we face.
All right, we have time for one more comment or question from the committee. We'll go to Carolyn.
Hopefully this will be quick, Jane. I live in a very rural region where, as an African-American woman, I know for a fact that there is less than a 1.4% African-American population in a 9-county area. Topping that is the reality that I came to recently that 1 out of 4 African-American babies at one of our major regional hospitals does not leave the hospital. They die there. 1 out of 4. To me, that is outrageous. I think there's something way deeper going on. My question specific to what we're talking about today, because I think this is wonderful information, excellent program, and I'd love to see more of this and glad to hear what you were sharing, Parker, about expansion with other plans. But my big question is how is education getting out to the general community about these efforts? Because I'm a professional in the community, skirting around doctors and medicals and sitting at this table. I'm just learning about this program. And I'm trying to figure out how do we get this out there more en masse so that we can see faster results. Maybe you're already doing that, but what programs would I be asking for as I contact my local representatives from Partnership or Anthem?
Well, really quick, the biggest change that has happened recently is the actual existence of the doula benefit in Medi-Cal, right? That didn't exist until Jan 1 of last year. So yes, and then there was this whole period where it wasn't implemented because we had to get the rate set right with DHCS. Then when we started implementing it, that's when the education and outreach began in earnest, right? That's outside of the programming we were already running. So again, it's a staged approach, but to me, it really is about education, right? I mean, and you can see from Tiffany's side of the house, the OB practice consultants that are on her team, this is what they do all day long. When they reach out to a new OB practice that we're working with or someone they haven't touched before, they go through the slate of services that we want them to think about as they're dealing with people in their catchment area, right? So these are pieces of process, but ultimately lead to outcomes, right? So we have to build it the right way. And I'm surprised that there isn't more visibility in your area, but I'm also happy that at least there's some movement there, but obviously 2 doulas for 700 deliveries a year probably doesn't cut it, and we've got to just get better. But I don't want to take away from the other solutions, right? It's a comprehensive packet. Doulas is one piece. Getting people more engaged in their own healthcare is another, right? Whether it's digital or otherwise. If moms can do a counseling session off their phone, why wouldn't we give that to them, you know, in between jobs or whatever it might be when they have that 10 minutes or 20 minutes to do it, right? And not make them travel. So we're approaching this from a, let's meet our member where they want to be met. That's part of our maternity mission at Anthem. That's also very much part of our digital strategy. We want to be a digital first company. We want to get people what they need, when they need it, at, with the modality of their choice. And that's going to take, again, the rollout takes time to get it done. But I'd be happy to reconnect and see how we can help you.
Definitely. I say that with all heart earnesty because I am the chair of a 9-county advocacy coalition. And like I said, skirt around all of the medical professionals, all of the legislative professionals in that region. These are the programs that we want to get out there more. So if I could please, have.
I will say, unfortunately, Anthem is no longer in the northern
not
counties.
in the Medi-Cal.
Not in the Medi-Cal space,
okay,
but
we are still in the
for everything else.
Side.
Yes.
So.
Yeah. And that was no choice of ours, by the way, just to be clear.
All right. Thank you very much.
Thank you.
Concludes our presentation. This presenter, and I'll invite Margareta up to introduce our next presenter.
Thank you. I just wanted to thank the Anthem Blue Cross team for sharing their cost reducing strategy, and thank you all for your excellent questions and comments. And now I'd like to introduce the Sharp Reese-Teely team to share their cost reducing strategy focused on population health management. So we have Stacey Orantes, the CEO, Andrea Snyder, Vice President Health Services, and Dr. Andy Dang, Chief Medical Officer. So again, we'll have presentation and time for questions and discussion.
Thank you, Margareta. I have the easy job. I get to introduce Sharp Reese-Teely. So the next slide, please. And the next one. That's beautiful San Diego, in case you want to come and see the ocean. So Sharp Reese-Teely, who are we? We are the first multi-specialty medical group in San Diego, and it was created by 2 physicians, one a GP and one a surgeon. And 101 years ago, they truly believed that coordinated care was the best care for San Diegans, and we've been building on that for the last 101 years. Next slide, please. So Sharp Reese-Teely joined Sharp Healthcare in 1985, and that happens to be when we signed our first capitated contracts with Pacific Care and Secure Horizons, if you remember those organizations. I like the best laugh. Okay, so we have 3 kind of associated medical groups, Sharp Reese-Teely being the only multi-specialty medical group. We have 4 acute care hospitals and 3 specialty hospitals, and we also have a not-for-profit health plan. Next slide, please. And so Sharp Reese-Teely, by the numbers, you could see we've grown to 700 physicians. When we joined Sharp Healthcare in 1985, we had 65 physicians. We have 19 clinics across San Diego County, and we have 2,800 employees supporting those physicians and our patients. The one point I'd like to really highlight here is that 70% of our revenue is capitated or prepaid. So for all of our HMO products, we are capitated on the professional side, and for all except for one payer, we're capitated on the hospital side. So we've been taking care of the full continuum of care for the since 1985, and we've really grown our programs. We have about 183,000 HMO members, and then we have Medicare fee-for-service, PPO, and occupational medicine. Next slide. And I'm going through this fast because really they have the experts and they have the best information. So I want to hurry up and get to them. This slide just shows the services. We have 1.7 million calls to our call center and 2.1 million lab tests. That was pre-COVID. And then, of course, our physician visits are about 1.5. Next slide. And remember, San Diego is bordered by Mexico, the Pacific Ocean, the desert, and thank goodness for Camp Pendleton, right? So LA and Orange County cannot come to San Diego very easily. Sorry, Barry. So my last point, besides that one, was the Sharp experience. This is something that really defines who we are as an organization, and it really defines our culture. Over 20 years ago, we started this journey to be the best place to work, the best place to practice medicine, and the best place to receive care, and believe it or not, in the universe. And it's a goal that we continually try to improve. It's really a process improvement initiative to really improve the things that we're doing for our patients, and putting the patient first, as well as for the care teams that support them. So it goes with the heart, right? So it's not just improving care, improving quality metrics, but it's doing it with compassion and putting that patient first with your heart. So with that, let me hand it over to the experts that are right behind me.
Okay. Oh, hey, I was able to advance the slide, so we're off to a good start. In addition to the Sharp experience, woven into the culture of Sharp Reese Daily is really this value proposition. And as Stacy mentioned, we take, 70% of our revenue is from capitation. And so we feel very strongly that we want to take responsibility for the entire patient and keep them healthy at home, work, and play, as Stacy likes to say. And so part of this value proposition is really that we deliver on quality and service. And IHA has recognized us as top 10% in clinical quality and patient experience, and the top quality, I think we've been like 4 years running. We also get from IHA Senior Medicare Advantage 5-star scoring. And so really that demonstrates the commitment we have to take care of the whole patient. And that requires investment. I think you've heard that theme throughout the day today, that these outcomes come as a result of thoughtful investment, and it takes years to produce the outcomes. We've invested in our population health teams, which I'm going to get into in a little bit more detail, our utilization management team, a whole lot of support that wraps around our physicians in the clinic to help them take care of patients, things like virtual on demand. So our patients can reach out and have kind of like a virtual urgent care visit with one of our physicians. So they have access to the record, they know the patient, they can see exactly what's going on and help manage them, hopefully keep them out of the urgent care and the emergency department. We also have 68% of our patients that are activated in our bidirectional patient portal, so they can reach out and send messages and get advice from their physician, get a refill request handled, all remotely at where they're at, speaking of meeting patients where they're at, outside of what counts as visits and encounters. And so really that's our true north, is taking care of the whole patient. And it did go to the next slide. So our population health department is really robust. We've been at it for many years. And one of the frameworks that we use for ensuring that we're sort of best in class is that we've pursued our NCQA certification for population health. It does take an investment to go through the survey process and provide a structure that meets all of the demands of NCQA certification. It starts with really identifying who our target population should be. And so I bolded and underlined data integration because we could not do our work without our amazing data team. They mine our electronic health record. They have access to a robust data warehouse. And over the past 2 years, we actually developed a new predictive model-driven high-risk list, which provides a list to our case managers to reach out to engage in patients that aren't currently engaged with the population health team every week. And that predictive model helps us to make sure that we're spending the time on that outreach on the right patients that really need our services. We stratify our population into risk levels and target resources at them, which I'll show you in another slide. Measuring the outcomes and delivering that data to the physicians and the clinicians, case managers, all of the folks that can have an impact on those patients' quality and outcomes. We want to tee that data up to them and make it easy for them to do the right thing. We also collaborate with our care delivery systems, health plans and payers, and community resources to make sure that we've wrapped the right services around the patient tailored to their specific needs. So all of that, oh, I did push it forward. Okay, can somebody go to the next slide? Thanks. Okay, so in terms of stratifying the population, we put them think of them in terms of this pyramid. So we have the walking well at that baseline. Those are patients that need preventive care. We engage them with our Center for Health Management. So they might be a patient who is pre-diabetic, so still fairly healthy, but that hemoglobin A1C is going in the wrong direction. And so we engage them in our diabetes prevention program, which is Medicare certified. And we actually, 88% of participants in that program meet one of the outcomes that CMS sets, and that is reducing hemoglobin A1C or losing, I think on average, they lose like 6% of their body weight over the year program, which is really impressive. also because we want to prevent them from progressing up this pyramid and prevent things like renal disease and dialysis 10 to 20 years from now. But I think it's really important, back to that theme of investment, that it takes investing now to prevent negative outcomes 10 to 20 years from now. So moving up the pyramid, you see we've got specific programs for chronic diseases, patients that do progress to diabetes. We have programs for them, congestive heart failure as well. Case management teams that are specialized in those areas and engage with those patients. We also have, going up the pyramid, patients that have multiple chronic conditions and complex case management for them. And then at the tip of the pyramid, we also have a care at home program. So we have nurse practitioners, case managers supported by social work and care specialists that actually go out into the home and provide essentially primary care, robust primary care with wraparound services in the home. And so, you know, on the left-hand side, you see that you leverage technology both up and down the pyramid. And as patients move up the pyramid in terms of their complexity, the resources around them are increased. Go ahead and go to the next slide. Examples of the team we have about 70 FTEs on our population health team. That includes certified RN case managers. They are really at the heart of population health, but we recognize that that's an expensive resource and have been able to augment what they are able to do for our patients with care specialists, community health workers, medical assistants. We especially have grown our licensed social work team. And I think it's been probably 5 or 6 years. We started with 1, we now have 4. And you know, to the doula conversation around connecting with patients at a very human level and helping them access the resources that they need. Many of these team members do exactly that kind of work at the right level. We have certified health coaches that will engage with patients on specific goals. So maybe somebody doesn't want to participate in the the diabetes prevention program, but we can hook them up with a health coach who will do 6 to 10 consecutive sessions with them around specific goals and help them accomplish those goals. Again, meeting patients where they're at. And then we also have diabetic educators that work with our diabetic patients. So go ahead and go to the next slide. On the theme of technology, and I think one of the positions we had called out there was project managers. It's really important for us to have that kind of support staff to help us leverage these kinds of programs. So for remote patient monitoring, we can put scales, blood pressure cuffs, continuous blood pressure or blood sugar monitoring in technology in with the patient so that we can keep close tabs on them. We actually don't take the mindset of let's put a scale in your home and you're going to have it for the rest of your life. We actually want to teach and coach those behaviors with patients. So we try to put the technology in the home, and then once they've established that habit of daily weights, then we make sure they have a scale of their own and we take the high tech out, but we've engaged them in their healthcare. And we also have texting programs. So when a patient graduates from an intensified case management program or graduates from having the high-tech scale in their home, then we have a wide variety of texting programs that check in on them. So for lower cost, we can expand the touches we have with our patients and stay in touch with how are they doing with their weights, how are they doing with their blood sugars. And if there's a problem, it's an easy way for them to reach out. We actually have a story where a patient was having stroke symptoms, and the only person that they had the capacity to reach out to was texting their case manager. And the case manager recognized what was going on, called 911. Patient thankfully was able to walk out of the hospital having received excellent stroke care. So we really are a touch away for these patients. Go ahead and go to the next slide. These are examples of the texting programs. We have, I think, 19 in total now. Some of them are diabetes prevention, diabetes, so very specific to disease conditions. Some of them are around condition management. We also offer a post-hospital discharge program to try to keep tabs on those patients when they're at risk for readmission. And then we have programs like our postpartum depression screening, where we didn't have a proven ROI to do this, but we recognized that it was a need, and we recognized post-COVID and with the expansion of our social work team, there is really an increasing need for mental health care for our postpartum patients. And we actually get about 80 referrals per month into our behavioral health case management program from our postpartum depression screening texting, which has been really powerful. Go ahead and go to the next slide. So examples of patient stories. This happens to be an example of a patient who was, we had outreached to her because she came up on one of those data lists that we get around diabetes. And she said, oh, you guys are amazing. I've been in the DPP program. I'm already signed up for the next one, which is our Be Well for Life, with it's kind of like a lifestyle medicine program that many patients graduate into. And because of her involvement, her hemoglobin A1C is down from 6.4 to 5.9. She's lost 23 pounds. She's exercising 5 to 8 times a week, and her husband is like, you've created a monster. And so it's just wonderful to hear these stories. Go ahead and go to the next slide. Another story, this is an example. These are pictures from a patient who was engaged with a health coach around improving her diet. I believe she was pre-diabetic. And she actually she was so proud of how well she was doing with creating healthy meals. She started texting pictures of those meals to her health coach, and they're beautiful. You can see she's eating the rainbow, and definitely lots of fruits and vegetables. Go ahead and go to the next slide. Last story. So, speaking of preventive care and identifying issues now that prevent furthering of disease and cost down the road, we've really ramped up our colon cancer screening and focused on Fit First. So, a test that patients can do at home if they're normal risk, and on an annual basis, we mail them a kit. They take care of it, mail it back, and we keep track of them. This happens to be a healthy father in his 40s, married, 2 kids, doing all the right things, exercising, eating well, and he found out that he was due for his colon cancer screening, and lo and behold, the FIT test was positive. So he progressed to a colonoscopy diagnostic. They found polyps, they were removed, and he is thrilled to have had this early screening to prevent further disease. And actually it inspired his father, who had been dodging a colonoscopy for many years to get one, and they found a tumor, and he was actually successfully treated and is in remission. So it goes beyond just the individual patient, but also touches their family's lives. And I'm going to turn it over to Dr. Day.
Thank you, Andrew. And I would say we try to leverage technology. If I get the next slide, at every space, right? And there's a big investment. And I want to share with you some of the outcomes that we've had. So you can see on the screen here, our senior patients admission rates over the years. And you can see that it's been going down, and we sort of plateau at the bottom there. But it's a tremendous investment. And how do we get there is by using our case managers, right? RNs, connecting with patients in their homes, making sure they're taking the medications, avoiding all the pitfalls that leads them into a hospital setting. So trying to catch any symptoms of a chronic illness early enough so that we can act upon them. That gets escalated to the physician, the clinical care team. Let's act on it. Let's do something to keep them out of the hospital. If they get in the hospital, once they leave, we get them an appointment to see their primary care doctor or their specialist, depending on what their needs are, within 7 days. And when they get there, they have a case manager participate in that visit with that patient and their primary care doctor. So I think there's a lot of things that we do to help support our patients to bring down that low admission rate. Technology is another part that Andrea spoke about. Text messaging platforms, right? That post-discharge program is all the things. I subscribe. I get my healthy living text message twice a week. Mondays around 10 o'clock in the morning, and Fridays around 10. And it reminds me, Andy, you need to get your flu shot. Are you eating your vegetables, etc.? So I think we leverage as much as we can to support our patients and to meet them where their needs are, right? Because we can't continue caring for our patients in our brick and mortars anymore, right? So we really want to move care into the patient's homes and anywhere there, whether in the car, whatever way we can interact and engage with you, that's where we're heading to. Next slide. So diabetes is a chronic illness for us, right? And here we go again. In the very left side of the bar, you can see 2009, 2010, which is I think the orange and lime green. And those were our rates per 1,000 patients with diabetes who had heart attacks and strokes. Let's focus on those two sides. We started our population health program there. Then we're interacting, we're making sure our patients are getting the labs drawn, we're working with primary care physicians, endocrinologists, the specialists to care for these patients to bring their diabetes under control. And because of that, we've been able to decrease the rate of heart attacks and strokes. This is the right thing to do for our patients. You see a little blip in the last 2 or 3 bars there. That's during COVID years. I'm not sure how to interpret that yet. I'm really curious to see how we come out of this and what will end up happening. You'll see in the middle the diagnosis of retinopathy, which is an eye disease for our patients with diabetes at high risk that can lead to blindness. You'll see a blip that's gone up over the last 3 years, and that's because we actually introduced better screening for our patients. So we invested in technology, we invested in optometrists. So you go see your primary care physician, and we got this little camera you put up to your eye. Within 5 minutes, we take a picture. That picture gets uploaded to the web. We have our own optometrist pull it within 24 hours, read those images, and say, your eyes look great, we screen you again in 2 years. Or they say, you know, there's something there. They send it off to their patient service representative at the front desk, calls the patient, hey, Andy, we saw something in that screen. Let's make an appointment. We'll bring you in. We'll skip that primary care doctor. We're going to bring you in directly, right? And we'll take care of it. We'll get a better view of that. We want to make things easier for our patients, right? If you make it easy, they get it done. When you, I believe one-stop shopping, right? You go to see your primary care doc, you get all this stuff done, you get this, you know, your eye test done. You don't have to go see your optometrist. It's great, it's convenient, it provides better, high-quality care for our patients. Next slide, please. So I'm a hospitalist by training, and one of the things that bothered me over the years being a hospitalist was, your patient would come in, they would get a hip surgery, an elective hip surgery done, right? A hip replacement or a knee replacement. And then somewhere along the lines, as I'm co-managing these patients with our surgeons, the discharge plan breaks down, right? So you may need to go to a skilled nursing facility because that care plan that you had, your relative from Maine, whoever was supposed to come and take care of you, didn't show up. Or they don't tell the surgeons, you know, I actually live, and this is a true story, on a second floor, 10 steps going up after a hip replacement, no elevators. They can't get up or down. They can't do their grocery shopping. So we created this program to really look at post-discharge planning for a patient with an elective surgery. It started out in the orthopedic space, and we spread it out to other diagnoses. They're going to call me as a patient. A social worker will give me a call, say, Andy, so this is what you expect. These are your operating dates. We expect you to be discharged on this day. Let me set up that first physical therapy appointment for you. So even before you hit the hospital, you have a physical therapy appointment, date, time, location, address for you to go to. That's fantastic because we're doing the things to improve the quality of care for our patients. And then we also solidify that plan because we call them, whoever they identify as their caregiver, we make sure they're going to show up. We make sure everything's done. That walker they need is there at home for them, waiting for them already. So they're not waiting to get home and get a delivery. So we're trying to get them to be as successful as possible. And because we've done this, we've been able to reduce emergency room visits 30 days after their surgeries and even decrease our length of stays because we've given our surgeons more comfort and trusting in the system that everything's set up for them already. So we're not trying to do it while they're in the hospital. It's done preemptively. Next slide. So this is what we sort of strive to do over, you know, we intentionally go down this road of trying to achieve that quintuple aim, right? We take a look at our population, try to provide the highest quality care across the population. If we do what's right for them, we lower the cost of care. We focus on clinicians' well-being. You know, we hear burnout is a big topic over the last 5 years. It hasn't gone away. But if we make things easier for everybody, burnout can improve, and we're working on that health equity. Next slide. Last but not least, we've gotten into the social determinants of health. So what we started doing was screening patients for food insecurity as well as living alone. We identified several years ago that if you live alone, that's a risk factor if you end up in the emergency room. So we really want to tackle that. We're going to screen these patients. And that's where also leveraging technology comes in. I get food insecurity screening once a year through here. So I answer that. It's a simple 2 questions. I answer it. That's how one of the ways we screen our patients. And this is something that we've done since the days of COVID. And we even use foundation funds to help patients who we identify being food insecure, just to get them to that next paycheck or something. Because if they can't afford food, they can't afford the medications, right? And that leads to poor health outcomes. So a lot of great work that we've done to help support our patients, but it takes a lot of investment, whether it's nurse case managers, social workers, technology, etc. And I think that's it. Questions?
Go ahead, Ken.
Yeah, great presentation. I'd like to inquire about what your philosophy is on integrating behavioral health into your primary care.
So I can start with that. We're actually we want to do that. We have participated in the California Quality Collaborative CalHive integration project. So we're working on that, and we're 6 months in, about. So
it's a 3-year collaborative.
So it's something that we want to meet, again, the idea of meeting our patients where their needs are. So we really want to try to get this to work. So we're in this pilot, and we'll see how it goes.
Yeah. So, and we know it's the right thing to do. So we've embedded social workers. Our 4 social workers actually take turns. We've selected one primary care clinic where they each spend a day in clinic. Haven't figured out how to make it pencil, but we know it's the right thing to do and that there's a definite need. And so excited to be a part of the collaborative. So yeah, shout out to all the CalHive members.
All right, any other questions or yeah, Andrew?
Just a quick question. You'd mentioned this was for 70% capitated lives. I'm just wondering, are the same programs available to non-capitated lives, PPO self-funded, just point of curiosity. I'm from Kaiser, so.
Did one of our PCPs put you up to that question? We get that question a lot, and unfortunately, most of our programs are targeted at our HMO population because we have the PMPM to support investing in the infrastructure. The medical group has actually generously funded some of the diabetes population targeted services because it's such a help to the primary care physicians, but yeah, we're focused on our HMO population.
And then I think to add though, a lot of our programs through the Center of Health Management, health coaching things, they're free to a lot of our patients.
Oh yeah, excellent point. Yeah, and the postpartum care actually, we provide that screening for all of our patients.
David?
I just wanted to say congratulations, amazing numbers, amazing programs. I'm in this area too, and to get the 170 or so admissions per 1,000 in a senior population is really impressive. You're avoiding a lot of unnecessary hospital visits, which is great for patients and great for the cost of the system. So congratulations.
Thank you.
Ivana?
I thought these presentations were really excellent. As Union Health Plan, we started doing care coordination and diabetes programs a while ago. We thought it would save us money, but mostly just we felt like our folks really needed the help because we represent low-income hospitality workers. But we found over time that we were able to study certain parts of our programs and realize there was an ROI, which was great. And this is exactly what we've been talking about, and sort of maintaining costs. We kind of keep hearing like, oh, we have to recruit doctors and there's going to be access problems. It's like, no, we want this kind of reaction to the 3% 5 years. It's like, let's go out and find more innovations like this. I do have to say, though, I think this is also works best when purchasers are also actively involved as part of the equation. I know that we certainly had to do a lot of work with Kaiser, and Andrew, pay attention because I'm going to say something nice for once about Kaiser. We partnered with Kaiser because Kaiser had these programs and our members weren't using them. And we had to go out, get our members, encourage them to use it, and then let Kaiser, do its job. And Kaiser, recognized that and actually gave us, a reduction in our rate a couple of years in recognition of that because they believed that they would see the ROI. These programs had been studied and we didn't have to wait 20 years to see the diabetics not have the complications. Because that's part of the problem that, you don't want to make the investment because you don't know if your employee or your patient's going to be with you 20 years down the road. A lot of ours are because they stick around these union jobs. So I just, I think Andrew's question was a good one. How do we expand this outside of an HMO population? And how do we also just, when we know that there's going to be a return, how do we bake that into, the incentives up front instead of just waiting for it down the road?
Thank you. Barry, go ahead, and then Carmen.
I think this is a perfect example of how we need to look at the value of APMs. And when we revisit our targets by product line, how quickly we'll get and what percentage we'll get APMs product by product, we need to move faster and further.
And the IHA Atlas really demonstrates that the HMO population gets better care, they have better outcomes. So I think it's important.
Yeah, thank you for the presentations and both to the, oh, I don't think she's there anymore, the previous presenter. It's not specific to the program that you all are talking about, but, I just wanted to kind of raise the issue of, I want to make sure that these types of, moves towards cost saving isn't replacing in-person care. I heard you say that, the plan is to get rid of brick and mortars. It's a little bit concerning generally to me to focus on the technologies. We've heard, our members at the California Nurses Association, we heard horror stories during COVID where people were being sent home with pulse oximeters, which one has the issue of not being able to properly calculate the blood oxygen levels of people with melanin, but then also issues of people like not taking off the film on the pulse oxes. So, I think we can't necessarily jump straight into technology without actually understanding the implications of doing that. And just because folks say that there's a convenience factor there, like there may be something missing with the move to remote patient monitoring. We want to make sure that these are supplemental to the in-person services, that we're still trying to, make sure that folks are getting the home health services that they need if they're at home. I think the struggle is real, and that like Carolyn and Peter were saying earlier, that there's a very fundamental problem of not having enough of healthcare workers, doulas or otherwise, as well as the actual infrastructure that we need. And so I want to make sure that we all are looking at this in a way where we're not ultimately reducing the number of services, whether it's the people or the actual structures. And this is not to say that this is anything that you all are trying to do.
Can I comment real quick? So I agree with you. We still need physicians. We still need nurses, because someone with abdominal pain still needs someone to press on their belly, right? And there still needs to have a home health nurse come in and do a urinary catheter change or check an ileostomy or something along those lines. These are augmentative services, because the reality is, right, as a primary care physician, you may see your patient every 3 to 4 months. What happens in between? So we got to keep that ability to keep connected to our patients. And someone said it here earlier, help empower them also, right? So this is one piece of the puzzle. This is not the solution, right? Technology at this present time is not the solution to great healthcare, but it helps augment where we're deficient. And I think in a lot of places, it can even improve healthcare. So in our diabetes text messaging program that we have, to your point, those who interact with the case manager have a much bigger decrease in the hemoglobin A1C by 1.1, 1.2%, but those in text messaging still get an improvement by about 0.8%. So it's still significant. It's not as good, but we want to meet our patients where their needs are. So the patient may say, hey, I don't really want to talk to somebody, but I'm willing to do a text message program, whatever it is. So let's not limit the choices of our patients. Let's try to expand the choices to engage them where they want to be met. So I think that's where the technology part comes in. It's filling that gap and also giving patients more options. But ultimately, you still need a physician. You still need people, and this should not be taken as let's take away the people. So,
Joan?
I apologize. I had to step out and get some water for a moment. So we can talk after if you already addressed this, but can you talk a little bit about how you've been dealing with things like language access and some of those, and how you've been handling some of those equity challenges? Because I see sort of the equity pieces in the slide, but I know I missed that part.
Sure. Yeah. I mean, just like everybody else, we do have translation services for patients that need it. Our Spanish speaking population, I think language preference is about it's less than 10%, I want to say. So it's not, I think I heard somebody speak to 85% of their patient population, which obviously is a bigger challenge, but we have been able to recruit, for example, diabetic educators and health coaches that speak Spanish. And so we target those resources at the sites where that language is more prevalent.
Yeah, and we do a population assessment every year and look at the numbers. They haven't changed very much. And we try to target and bring resources to that area. So it's an active thing that goes on every year.
Any additional comments or questions from the committee? All right, thank you to our presenters. This concludes that portion, that agenda item. So we will now move to public comment. Those interested in making comment in the room, please step to the podium. Those interested online, please raise your hand. Seeing no one in the room at the podium, moving virtually, noting we have about 60 virtual attendees. Seeing no hands raised, we'll give it a moment. That concludes public comment on this item. I'll turn it back over to Margaretta Brand.
Thank you again, and thanks again to our presenters at Anthem Blue Cross and Sharp Race Daily. Really appreciate their presentations this afternoon. And so for this next portion of the agenda, I'll be walking through an update of our work underway on one of our focus areas for promoting a high-value health system, and that is workforce stability. So as usual, on the next slide, we'll begin with a discussion and an overview of the statutory requirements for monitoring workforce stability. So OCA is charged with monitoring workforce stability in 3 ways. One is monitoring the effect of spending targets on workforce stability, ensuring that workforce shortages do not undermine healthcare affordability, access, quality, or equity, and promoting healthcare affordability while recognizing the need to increase the supply of trained healthcare workers. So in consultation with the board, we'll develop standards to advance healthcare workforce stability by July 2024. And these standards will be used to monitor workforce trends and promote stability as we implement the spending targets. And of note, these standards themselves are not enforceable, but on the next slide, I'll talk about our enforceable standards, which are workforce stability standards that could be implemented alongside a performance improvement plan. So the board would approve workforce stability standards that may be incorporated into a performance improvement plan that OCA could require of entities who are not meeting the spending targets. And these standards would be enforceable. And so today I'm going to focus on that first set of standards, the general standards to advance workforce stability, and not these specific standards that would be used in a potential performance improvement plan. So on the next slide, I'll just a little bit of background. I'm sure many of you are familiar with most of what is on this slide, but California currently faces a significant health workforce shortage, including a geographic imbalanced distribution of workers, especially as recognized by the California Future Health Workforce Commission and other programs that look to monitor and strengthen the healthcare workforce, including our very own HCI workforce programs. So the healthcare workforce challenges contribute to lack of access to needed services, especially preventive services, delays in receiving appropriate care, and preventive hospitalizations. And as the Health Affairs Council on Healthcare Spending and Value noted, that efforts to slow spending growth may have unintended consequences if healthcare entities reduce spending through staffing reductions. And we know that a stable, well-prepared, and adequately supplied workforce is essential to a sustainable healthcare system that provides high-quality, equitable care to all Californians. And to date, no other state has implemented workforce stability standards alongside its spending target. So California is entering uncharted territory here, and I'll use the remainder of our slides in this portion of the presentation to provide an update on the approach we've taken and what we've learned so far. So on this slide, you'll see our approach outlined with a variety of steps. And to support the development of these standards, OCA has contracted with the Institute for Health Policy Studies and Health Force Center at the University of California, San Francisco. So this slide again provides an overview of our approach to developing the standards, and highlighted in orange is kind of the progress we've made so far. And the next few steps are what's coming over the next several months. So we started with a literature review to review research and current evidence and initiatives on workforce stability. We also conducted a data set and metric review to review available data sets and identify relevant variables to operationalize workforce stability standards. And then in late fall, we conducted interviews. We conducted 2 sets of interviews, key informant interviews with state and national workforce experts to discuss how spending targets might affect workforce, and then also to solicit insights to inform the standards and the metrics. And then we also conducted stakeholder interviews with healthcare entities, organized labor, and consumer advocates to understand their perspectives. So, using all of this initial work, we are currently drafting standards, and will conduct additional interviews to obtain more feedback on the draft standards. And then we'll bring standards to the board, the advisory committee, and release them for public comment. Before and then after incorporating all of that round of feedback in the standards, we'll finalize them. So on the next slide, this slide essentially takes our approach and puts it into a timeline format. So again, those orange markers indicate where we are in our current timeline. We are currently drafting standards based on all of the feedback and the research that we've done so far. And then we are planning to present draft standards to the advisory committee and the board in March or April of this year. And then by summer of this year, we'll finalize the standards in consultation with the board, and then we'll begin our work to implement the standards. So on the next slide, I want to get into kind of the findings of our work so far and share some preliminary findings, and then have you all weigh in with any thoughts or questions based on our preliminary learnings. So from the literature review and the data set and metric review, kind of for context for these next few slides, wanted to share that we've grouped our findings into 2 categories representing levels or units of analysis of healthcare workforce. So there are studies and metrics that address workforce stability or workforce generally at the employer or organization level. And then there are also, studies or metrics that evaluate workforce at the labor market level. So at the organizational level, this would be workforce at an individual healthcare entity, such as a hospital, clinic, or nursing home, and employee turnover at an organization is an example of those types of metrics. And then for the labor market level, this more generally describes workforce characteristics and trends that impact healthcare occupations throughout a state or a region across employers. And this could include something like delays in professional licensure that affects all employers. So although we kind of discuss them separately, they're very connected, and there's significant overlap between employer and market level findings. And we really recognize the important interactions between the two, and how they both shape the stability of the workforce. So if we could go to the next slide. Sharing some key takeaways of our literature review. Again, they're organized by employer or organizational level and labor market level. So UCSF's review of the peer-reviewed literature and gray literature on workforce stability found that at the organizational level, there's no consensus definition of healthcare workforce stability. And measures of turnover and retention are most often used in the literature, although definitions of what those mean vary across studies. And both turnover and retention are important to understanding workforce stability. And of note here, intention to leave or intention to stay are frequently used as proxies that may not accurately reflect turnover or retention. So those are often based on studies or folks sharing information through surveys. So most studies also measured voluntary turnover, which is when employees willingly choose to leave their professions, and the causes and potential measures to address voluntary turnover would significantly differ from those for involuntary turnover. And involuntary turnover would include layoffs or terminations for poor performance. And at the labor market level, the literature points to factors such as licensure delays, poor working conditions, low wages, mismatches between population need and economic demand for workers, and exits from the workforce as contributing to labor shortages. And we know that labor costs are a major contributor to overall healthcare costs. For example, turnover costs and high payment rates for contractor workers are two elements of labor costs that could be reduced when the healthcare workforce is stabilized. So, an important overall conclusion of this literature review is that there's no current literature that exists that directly evaluates the impact of healthcare spending targets on the stability of the healthcare workforce. So we're looking, more broadly at workforce stability. And on our next slide, we'll walk through what we've learned in terms of the data set and metric review. So, to monitor workforce stability, we know that we need to use metrics and use reliable data to monitor stability. So UCSF reviewed 13 state government, federal government, and non-governmental data sources to track elements of workforce stability at the organizational level, and then another 12 at the labor market level. So of course, data from HCI on hospitals and licensed primary care clinics is really important for organizational level measurement. So for example, HCI tracks the total number of hours worked and average wage for several occupational categories for all hospitals, and has similar but less detailed data for all licensed health centers and long-term care facilities in California. Other potentially relevant data sources include the California Employment Development Department's quarterly payroll data, which tracks employment trends at the organizational level, and then CMS's payroll journal, which monitors workforce and employment in nursing homes. So OCA would potentially need to develop agreements with some of these entities to obtain organization level data. And there are also proprietary data sources such as the Hospital Association of Southern California, which measures vacancy and turnover rates for hospitals throughout California. And then turning to the labor market level, some national sources such as the American Community Survey and the Bureau of Labor Statistics Occupational Employment and Wage Statistics Survey can be used to monitor California's supply of unlicensed healthcare workers. And then HCI also collects license renewal survey data from 21 healing arts boards in California that tracks supply and geographic distribution and demographic characteristics for licensed professionals. And then again, we could look to the Board of Registered Nursing or other boards for their data as well. And then to monitor professional education and training trends, the U.S. Department of Education's integrated post-secondary education system reports on numbers of graduates from bachelor's and graduate degree programs. And then just sharing in terms of overall, this review demonstrated that there are many publicly available data sources that we could use to track several valuable workforce stability metrics. And then just a note that there are, some data lags in terms of when the data is available for which years. And so whether data is publicly available and how frequently it is updated will be a really key consideration for the workforce stability metrics. And then moving along to our approach to key informant and stakeholder interviews. So to kind of begin our exploration of workforce stability standards in California alongside the spending targets, we sought input from a wide range of stakeholders. And statute directs us to seek input from organized labor representing healthcare workers, healthcare entities, and others with expertise in workforce. So we've interviewed 10 content experts listed here as key informants and 13 stakeholders representing organized labor, healthcare entities, and consumer advocacy perspectives. And these interviews often included multiple team members, more than just listed on these slides, or this slide, and a full set of interviewees is included in your appendix. And these were interviews in a semi-structured format using an interview guide to solicit perspectives on the potential impact of spending targets on healthcare workforce stability, solicit any recommendations for standards or metrics that we should consider, and any insights folks had on the standards. And then we will conduct second interviews once we have draft standards with some of these organizations to follow up and get their feedback on what we've developed. And on the next slide, I'll share some findings from our interviews. These are preliminary findings. The UCSF team is currently completing a formal analysis of the interview findings, but we wanted to share some early thoughts here. So these are both from the key informant and stakeholder interviews and listing out some potential benefits and challenges for the standards. So interviewees suggested that several potential benefits could exist through the development of these standards. For example, they could create a common language about workforce needs and identify drivers of workforce challenges. The standards could also identify employer responses to the spending targets that adversely impact patient care and by compromising workforce adequacy. And then several interviewees emphasized that improving the stability of the workforce has the potential to reduce wasteful spending and might even lower costs. And then on the challenges side, several interviewees noted that applying uniform statewide standards to a wide range of organizations, each with its own characteristics and workforce needs, might be challenging. And then also there's a potential for administrative burden with any new reporting that OCA may require and could add to any strain or workforce instability at different organizations. And then several interviewees also noted that setting rigid standards in the context of, our rapidly evolving healthcare system could stifle innovative care team configurations or redistribution of workers across a healthcare system to be more efficient. So on the next slide, I'll kind of wrap up what we've learned from the interviews. So the interviewees also identified some professions that may deserve more attention than others based on the context that we're working in now. So, for example, behavioral health workers might be a specific area of interest due to shortages. Nurses are dealing with burnout and leaving the profession, and then also direct care workers and support staff at long-term care facilities or nursing facilities are especially vulnerable due to their low wages and low job security. And in terms of metrics, we heard several interviewees identify, we heard lots of different ideas for metrics, but kind of key themes were retention, turnover, vacancy rates, time to fill positions, and layoffs. And if we go to the next slide, I'll just wrap up on what we've learned so far and describe our next steps. So all of the background work that I've shared today in terms of the literature review and the data set and metric review and our interviews inform our drafting of the standards that we are currently conducting. And then we'll bring a set of draft standards to another round of interviewees for their feedback again. And then in March or April, we'll present these draft standards to the board and the advisory committee for feedback and for public comment. And then, of course, another round of revisions and bring this all back to the board in June of 2024. So that wraps up the update on the workforce stability development, and happy to answer any questions or hear any additional feedback or recommendations.
Okay, so comment or questions from the committee. We'll start with Samantha.
I appreciate hearing about all the work and all the interviews. And as I glance at this, I see that there aren't primary care clinicians, and I wonder about that specific side. There are shortages across the board, no question. But just in terms of family medicine, internal medicine, are you going to be talking to people who are really looking at this specific primary care physician shortage?
Sure. So maybe that's a helpful clarification point for the overall focus of the standards. So based on our interpretation of the statute and the language that's in the statute, that the standards themselves are really intended to focus on the non-physician workforce. So folks like nurses and medical assistants and community health workers. So that's where we're focusing most of our effort. So we are not proposing at this time to include the physician workforce in these standards.
For the behavioral health workforce, I wonder if there's a way to get an idea of how many therapists are out there, maybe using licensure data versus how many therapists are actually taking insurance or are employed at a agency that takes Medi-Cal or private insurance. My understanding is there's, a big gap there that maybe there is more of a workforce, just not more of a willing workforce to participate in the current healthcare system.
Yeah, I'm not sure. I know we've talked about that issue before at the advisory committee, and I'm not sure if we'll be able to address that with the data that we found, but we can definitely, look into it a bit more.
Thank you. Go ahead, Joan.
Thank you for all the work to get your arms around this big project. I know that this is unprecedented and that we don't have as much to rely on from other states on this one. So appreciate the thoughtfulness from your team and the UCSF team on getting this up and running. And it's helpful to see some of those initial metrics pulled together. One thing that I don't see in that initial list of metrics is getting at some of the equity issues, whether it's language, whether it's racial ethnic background. And I mean, to Parker's example earlier of a doula is great, a doula who speaks Spanish would be much more valuable to that particular population. I know that this is going to be a crawl, walk, run, but how do you see us getting to run on some of those whether it's geographic, language, racial, ethnic issues?
Sure. So, and I welcome, I see Janet on the line from UCSF, who I'll welcome to add, but some of the data sources that we looked at, they do collect things like the race, ethnicity of the workforce and distribution by geography, although maybe it's more at a regional level or a sub-state level rather than, by county or smaller geographic units. So there are some ways we could get to that, but again, that may be some areas where we say we would need more data to do X, Y, Z. And I'm not sure if, yeah, go
so
ahead, Janet.
Margaretta,
Yes.
thank you. I think that's well said. Also, I think one of the things I want to shout out is that HCI's Health Workforce Research and Data Center, in the work that they are doing in partnering with the licensing board, is substantially increasing the data that are the data and the granularity of data to understand the workforce in licensed professions. Data, unfortunately, more limited, particularly in terms of granularity for the unlicensed. But yes, certainly we heard, we are in. I would say those data exist and are certainly. I think we want to include those markers of equity externally. That'll be our advice to OCA. To the previous question about therapists, number of therapists versus the number participating in insurance, unfortunately, the Health Workforce Data Center data will not help us there. However, with the another HCI initiative, the healthcare payments database, I think, again, this won't be the crawl stage, but I think there's potential perhaps in the walk and certainly in the run stage to be able to link licensing board data with data from the healthcare payments database that could help us answer those questions. Right now, we just don't have a great way to match up the list of folks who are licensed with data that would tell us who's accepting payment from Medi-Cal private insurers or other insurers.
Let's see, Parker, and then we'll go to Ken.
Also, thank you for doing this work, and even if it's not directly including primary care physicians or family physicians, it's hugely important, and so I appreciate that. But this is also a statement that, again, maybe echoing to the best value in a healthcare investment system we know is around primary care. And in our world, right, the National Academy of Sciences back in 2021 produced this landmark study looking again at primary care and kind of calling for the country again to get to that. And that there's robust data there on the big picture talking about for every dollar there, you're getting $5 to $14 of kind of return on investment long-term in a healthcare system. So while that was probably focused more on primary care clinicians, I think universally it speaks to the value of directing energy in places that would retain people and high value return long term for healthcare, and that's primary care. So thank you for doing this work.
I think isn't this problem further exacerbated by the increasing number of providers, especially in behavioral health, that aren't taking insurance as far as being accessible to people through their networks?
I think we can look into that, but I know we've talked a lot about that issue at the advisory committee as a whole, as kind of a gap in our knowledge and or data that we collect. But it's definitely something we could try to look into more. And I don't know if Vishal or Janet, if you wanted to share anything about how we might be able to further address that.
Okay, this is Janet. So I think I talked about it a little. I mean, no question that I think this is a huge area of concern. I call out the HPD because that will, pool insurance claims data from several different sources that would enable one. And I don't want to get out too far ahead of my skis on that, but certainly at least the raw data have potential, I think, to help us answer some of those questions, and would defer to Vishal in terms of what could be shared between the HPD and OCA to enhance our understanding and knowledge here. But that's what you would need, is some ability to look at the number of folks who are licensed in a behavioral health occupation and match that up with claims and encounter data to know what fraction of those folks are participating in different types of health insurance.
Thanks, Janet. That's definitely something we could take back with regard to in the future, if the HPD could be a resource for that. There's some complexities related to rendering provider organization NPI versus individual provider NPI, and tax ID numbers that are kind of not always have a neat one-to-one relationship. So that is something we could look into in the future.
Thank you so much to OCA and all the work that you've done in trying to grapple with the question about workforce stability. I do think there were a couple things that just kind of popped into my mind just looking at the data sets that you all are looking at. One of the things in the conversations about at least the nursing workforce, we've talked a lot about generally about clinical education, clinical placements. That could be something that's really important to look at both on the medical professional side and on, any healthcare professionals that need some sort of clinical placement and training, and how that operates and works to ensure that we have a stable workforce. And also, I know right now there's a focus on like, where are the healthcare workers? What are they getting paid? Where, very, very basic kind of picture painting. But I do, ideally, it would be nice to also try to look at the reasons why healthcare workers are potentially leaving either direct care positions, or why folks are moving within the healthcare workforce labor market, or leaving the healthcare workforce labor market. Like, one of the things that comes to my mind is injury and illness rates. Is that something that we could at least overlay in terms of monitoring what's happening? Obviously, Cal OSHA has a lot of data on that, and also the Workers' Compensation Division. So there's a lot of things in there that we could try to look at to see, like, what is impacting healthcare workers. Another thing that there's a lot that I can think of, but another big component is also student loans. I think some of us were talking about student loans earlier, and for both doctors and nurses and other healthcare workers that need a degree, that it impacts where folks decide to practice. And I can see us trying to figure out if that's actually impacting whether or not we can get new medical students who are, folks going into primary care, and if there's something that we can address on that level in terms of making sure that the correct, people are actually wanting to enter these workforces in areas of the state where they might be getting paid less currently.
Thank you.
That's it. But thank you all for everything that you're doing. Sorry for throwing so much at you.
No, thank you so much. Yeah, no, definitely the injury and illness rates came up in some of our interviews, so that's definitely something we can look into more. And then also wages and benefits, of course. So those are all in consideration for how we're looking at the workforce stability metrics. And I'm not sure, Janet, if there's anything you wanted to add there.
I think you covered that quite well. Yes. And I think
Okay.
I guess the only thing that I would say is, I think this calls out that, the reason, there are things that quantitative data and metrics can answer well, and things for which their ability is limited, and reasons why is one of those. So, Margaret, there may be something we want to think about as either maybe ongoing literature review or possible additional work to understand some of, those nuances that aren't so well captured in the data.
Mm-hmm. Thank you. Yeah, Jane?
Yep, we will go to Andrea, and then we'll go to Sarah Gavin online and Sarah Schroken in the room.
Yeah, so I'm sorry, I'm stuck at the 3% from earlier. I just want to think through, I guess I'm going to get your comments, right? Number one is just great, you're actually looking at the workforce stability. It is, very important. And I think the whole point of it is you have a spending target, want to make sure it doesn't hurt the workforce. But have you had a chance to actually talk to your stakeholders about the 3%? Because I'm thinking about all the shortages, the access challenges, we need to invest in primary care, invest in mental health, and, I'm back to 3%. So I guess it's a little bit of a conflict, or maybe it's not a conflict. I'm just trying to reconcile those two.
No, we did not in our interviews this past fall talk about the 3% number at all. Just generally about how a spending target would impact workforce stability and any broader impact it would have on the workforce. So, but we can definitely incorporate specifics and or more generally thinking about that in our upcoming interviews.
Thank you. Sarah Gavin, attending virtually, please go ahead.
Great, thank you. The question of the county behavioral health system in California keeps coming up for me. It's a huge body of the behavioral health, mental health, and substance use treatment work of our state. I oversee a very large behavioral health department that does integrated services in an FQHC, but also provides a number of county level behavioral health and substance use treatment services. And when we're talking about burnout and turnover and workforce, I still wonder where that huge body of work gets captured in the data. And I would just say, from my experience the last 16 years being in FQHC, that the highest rates of turnover in behavioral health come from the county level services, specialty mental health, drug medical services, and not on the primary care side. And there are distinctions and specific comments that I would have about why that is, but I think I'm just curious about how that gets folded into how we're making decisions about healthcare spending, but also, some of the factors that were just discussed around burnout and workforce. Thanks.
Thanks. Really good call out, Sarah. And I'm going to turn over to Janet. I don't remember seeing specific data or information on this, but we can definitely look into it. And Janet, anything comes to mind?
Well, and I will speak solely to the workforce data piece. I think historically we haven't had the best data to track the settings in which people are working. And I'm excited to see where the Health Workforce Research Data Center goes with that, to whether we're going to have more precise data, at least understanding where people are working. Right now, there isn't a good existing data set you can grab to understand whether there are differential, rates of turnover or burnout. But I think it is an important, and I can say, from work that our team has done for the County Behavioral Health Directors Association, I think it is fair to say that there are a lot of challenges with burnout and turnover. There, some, may having to do with the fact that the county system serves some of our folks who have the greatest need. But then I think there are also issues around competitiveness of wages and that also factor in there.
Great. Thank you. We'll go to Sarah Sorokin.
Maybe this is something that you've already been doing or thinking about, doing interviews with frontline healthcare workers. I mean, in primary care or in all different areas, but in behavioral health in particular, the unique challenges that frontline behavioral healthcare workers face in the workplace and why they may be burning out and leaving. And I have worked in many different workplaces, actually throughout the state, mostly specialty mental health services and also HMO environment. And one huge problem that I see is that mental health clinicians are very much monitored. Their clinical decision making isn't respected as one would expect as a licensed professional, because there is such a pressure to move people on out, and that is very morally distressing for behavioral health care workers, which makes a private practice environment just a lot more attractive, because you don't have to experience that kind of heartache. And in particular, specialty mental health services, although this can count maybe for a lot of different mental health, behavioral health workplaces, but seeing the most severe people in need being placed on wait lists, going into the hospital, all while waiting to get the help that they need is very difficult. I mean, counties, the one I work at included, they tend to look at neighboring counties when making decisions or to inform their decisions about salaries. And in that way, it's almost like a race to the bottom, because no county is able to, that I'm aware of, is able to really attract the workforce that they need. And if they're comparing salaries to neighboring counties, it doesn't seem to be a very effective way to determine a good salary and attract people, but that seems to be the practice.
Thank you. Really appreciate that feedback. And we did not directly interview any frontline healthcare workers, but that's definitely something we can consider, and we can reach out to folks to facilitate that.
Thank you. Any further comments or questions from the committee? Seeing none at this time, we'll move to public comment on this item. For members of the public who would like to make public comment in the room, please step to the podium, or those online, please raise your hand. Noting we have about 60 attendees online right now. Seeing no one at the podium in the room, moving back virtually, seeing no hands raised at this moment. That concludes public comment on this item. The time is now 2:48. We will take a 10-ish minute break until 15-minute break until 3:05. Thank you. That concludes our afternoon break. For this next item, I will turn it over to Assistant Deputy Director CJ Howard.
All right, good afternoon. We've saved the most exciting part of the presentations today for this time in the afternoon. Hope that you're all geared up and ready to go. I promise I will do my very best to not repeat myself as much so that we can get through this afternoon quickly. So I'm just going to be providing an update and response to some of the comments that we've received on the proposed regulations for total healthcare expenditures and the data submission guide. And I've lost my handy clicker, so I will be asking my colleagues in the back to advance slides for me. Again, yet another timeline that we have to share with you today. This one's a little bit different than the last. So we published the draft regulations in October. We had a public workshop in November. We discussed the regulations at the last convening of the advisory committee in November. I now have a clicker. That was not on the timeline. We had a board discussion in December. We concluded the formal written public comment period in early December. So we'll be providing a board update tomorrow at the board meeting, and we're still aiming to submit to the Office of Administrative Law the proposed regulations late this month, early next, with the regulations ultimately becoming effective in the spring of this year. So I'll go over the comments and the responses, the OCA's responses to some of the comments that were received on the proposed regulations. So one of the initial comments that we received was a request for clarity on how to prevent double counting of total healthcare expenditures when fully integrated delivery systems are contracted with another payer. In short, the proposed regulations require a directly contracted plan to obtain any necessary data from a subcontracted plan and to submit the data to OCA to prevent and preclude double counting. There was a request for clarity on how payers should determine which commercial category to report the spend in. OCA intends and has amended the data submission guide to create a new section titled Market Categories, which includes added language and examples clarifying the distinction between the commercial and commercial full claims and commercial partial claims market categories. There was a desire for standard patient attribution methodology and more clear guidance on how to attribute member spending, especially under the payer-developed attribution method. We will amend the language to clarify that attribution is calculated based on mutually exclusive member months and clarify the order of operations regarding mutually exclusive attribution. There's another comment on the absence of process for validating and or disputing expenditures attributed to providers. OCA, we acknowledge that there may be some variation across payers and fully integrated delivery systems in terms of attribution, and OCA acknowledges that not all TME or total medical expense will be attributed to physician organizations. While we are attempting to collect data that is needed to implement our statutorily defined goals, we note that we may not incorporate all data collected in our baseline and/or annual reports, and may not use all of the data that we collect for reporting, enforcement, or accountability. We will continue to refine the attribution methodologies to inform future data collection and reporting. We received a comment that there is an inadequate list of physician organizations in the attribution addendum, that it excludes medical managed care providers and many of the medical physician organizations, for example, counties that provide care and community clinics and restricted RBOs and RKKs. Our plan is that we will update the addendum, and our plan is to continually and periodically update this as we receive more information excuse me, from submitters. And that all updates will go through our Office of Administrative Law. There's also concern over omitting physician groups with 25 or more physicians. Again, our plan is to continue to amend and include the known groups that we have, and so we will be updating the physician organization list. One comment noted the need for a physician organization registry, and again, we acknowledge that we will continually need to refine this list for more complete data. There's another comment that the office should include the most pertinent portions of the data submission guide directly in the proposed regulation. The regulations are incorporated as the data submission guide is incorporated as part of the regulations as a matter of law. OCA determined that publishing the guide in the California Code of Regulations would be complicated, and that a user-friendly guide is the most appropriate means of communicating this technical information to technology specialists that would be responsible for ultimately gathering and collating and submitting this data. This approach is also familiar to many submitters of HCI's HPD program and those that participate in spending target programs in other states. There's a comment that there is a lack of a mechanism for gathering clinical risk information and could punish providers who serve particularly vulnerable populations, including a request to formally evaluate alternative risk adjustment methodologies. OCA will not modify its risk adjustment methodology to consider clinical risk through these proposed regulations. OCA staff indicated in the September 2023 board meeting that age, sex risk adjustment will be used for the baseline report. OCA will continue to assess this issue of whether clinical risk adjustment should be introduced into future reporting. OCA remains open to other approaches to risk adjustment and will continue to assess options going forward. There was a comment regarding the authority to collect self-insured data. OCA statute does not provide an exemption for self-insured data. The regulations require submissions of all data for market categories in accordance with federal law and provide for voluntary submission where data submission cannot be required. There's another comment regarding the authority to collect Medicare Advantage data. So OCA is asking for Medicare Advantage data that the state already collects for licensing and plan solvency, just extracted and aggregated and submitted in a format that lends itself to measurement of THCE growth rate over time. There was another comment regarding the claims runout period and that it may be insufficient and or inconsistent with state law and will lead to potential for error. So OCA acknowledges that for some claims runout may exceed the minimum 180-day claims runout period. This is one of the reasons why the DSG requires data submission for the previous 2 calendar years with each annual data submission, because the 180-day claims runout period is calculated from December 31 of the most recent reporting year. So in other words, from June 30 for 2024, for the 2022 and 2023 service dates, 2022 calendar year data submitted to OCA will reflect a claims runout period of at least 540 days. By collecting the 2 years worth of data, each reporting period, OCA will be able to and intends to use the initial data submissions received in 24 and 25 to develop further insight into the impact that the 180-day minimum claims runout period may have on overall data completeness. There was a request for new definition of the allowed amount. OCA did not adopt the suggested definition because the existing language in the proposed regulation seems sufficiently clear. The guide specifies that the allowed amount includes the amount paid by the payer or fully integrated delivery system. There was a request for clarity around admin cost and profit data collection. So data necessary to collect the administrative cost and profits for other submitters will be sourced from existing state and federal reports, including those maintained by DMHC, DHCS, CMS, Centers for Consumer Information and Insurance Oversight, and the National Association of Insurance Commissioners. There was also a request for an explanation for why Appendix B does not include non-claims total primary care, non-claims based payment. The instructions for how to calculate the portion of non-claims payments related to primary care will be determined through OCA's primary care subgroup meeting and investment payment work group. There was a request for additional clarity around what fully integrated delivery systems will report. The proposed regulations have identical data submission requirements for payers and fully integrated delivery systems. Likewise, OCA's expectations for data accuracy and completeness are identical for payers and for FIDs. OCA will continue to engage with FIDs and stakeholders through this initial data collection process to determine whether the existing service categories and non-claimed payment categories meet OCA's data analysis and reporting needs. There was a request to report cost sharing by benefit category, for example, inpatient, to show where costs are being borne by consumers. OCA will not add an additional data field segmenting payer paid and member paid amounts in these initial data collection regulations. OCA is committed to promoting the goal of improved affordability for consumers and purchasers of healthcare, and will evaluate the data collected to continue to inform future data collection and reporting. There was a request for a new suggested definition of pharmacy rebates. OCA declined to adopt the suggested new definition. The guide will contain a bulleted list of the types of pharmacy rebate data collected in the pharmacy rebates file. We're into the home stretch. There's a request for changes to the language in Appendix A for service categories. OCA will delete the outpatient observation services, critical access hospital, and freestanding emergency facility. There was a request to change to term doctor of medicine or osteopathy. OCA will revise to licensed physician and surgeon. There was a request for stakeholder engagement language added to the guide. OCA will add section 1.3 to the guide, changes to this guide, which will read consistent with Health and Safety Code section 127501.4K. Prior to making any changes to this guide, OCA will engage with relevant stakeholders, hold a public meeting to solicit input, and provide a response to input received. For notice of potential regulatory actions or public meetings, subscribe to OCA's email listservs at the provided web address. I'll open it up or turn it back over to Jane to facilitate questions or comments.
Questions or comments from the committee? We'll go to Ivana.
If you can go back up to slide 102. I'll take OCA response for $200. Yeah, okay, it's one on data collection. There you go. Okay, so the sentence that says the sort of on OCA response, the second bullet, the proposed regulations require a directly contracted plan to obtain necessary data. Does that mean that a directly contracted plan will have to start gathering encounter level information, including diagnoses?
The categories of data OCA is going to collect doesn't include encounters. It's claims and non-claim spending, and consumer out-of-pocket spending, and in this case, the subcontracted plan. It would, an example would be the way, just using LA Care as an example, they have subcontracted plans. So our regulations put the onus of data collection on the directly contracted plan, which is LA Care, who holds the contract with DHCS, as an example.
Okay, thank you.
Ken?
Yeah, I just want to pass on with regard to the absence of mandatory remittance of data. The Committee on Education and the Workforce in Washington, they're seeking comments on possible amendments to ERISA. And that would be the avenue for eliminating the restriction on mandating data from ERISA plans. So I sent a copy to Megan if there's any interest in pursuing that. Now, for anybody else who has involvement with ERISA plans, just getting away from that, I forget what the name of the Gobey decision, but now would be the time.
Yeah, thank you. We'll take a look at that comment letter.
Thank you. Additional comments or questions from the committee? Anthony?
Appreciate the review, the thoroughness of going through it, the consideration of the comments of my organization and others with regard to a variety of these issues, whether the process of regs or the data guide methodology. We do support the office's we do support the office with regard to moving forward with age sex as a modification of THCE in the spending reports, and the decision not to use clinical risk adjustments for the spending targets, since that we do continue to have concerns about upcoding and trying to and the issues that come with that, including the sort of non-intuitive counter equity implications that could result. So we appreciate the recommendations at this time.
Thank you, Anthony.
Looking virtually to committee member Eliza Adroyan.
Good afternoon. The one thing that we talk a little bit on the fringes about is encounter data. And because that constitutes such a large portion of the healthcare spend, and that we're not really talking about it. I mean, we're focused on claims and non-claims. And it feels like non-claims should include encounter data in a way where we're capturing the spend on that. You heard earlier from Sharp and the rest of the large integrated health systems, as well as the independent IPAs, are predominantly capitated. And the only way to capture that information is through encounter data, whether that's coming directly from the physician groups, the IPAs, or the health plans. And so if not, now at some point, that probably needs to be part and parcel of how we look at data collection and the costs. Thank you.
Yeah, thank you, Eliza. I just wanted to note OCA is going to measure the non-claims payments that include capitation, other types of incentives. And then as far as encounters, there is a plan, there is a phased approach to the way the HPD is being implemented, and in the future it will collect encounter data. So that's going to be helpful when OCA starts drilling down, because the data OCA is going to get is going to be aggregated. But then we're going to turn to the all-payer claims database, or HPD, in California to do kind of a deeper dive, which is going to include claims and and non-claims, and then, associated encounters with that as well.
Thank you.
Any additional comments or questions from the committee? All right. Seeing none at this time, we'll now move to public comment. For members of the public that would like to make a comment, please step to the podium. If you're attending virtually, please raise your hand. If possible, please keep your comments to 2 minutes. Going to the individual at the podium.
So as a result, we have to, some other mic I'm sure was picking me up, but I usually don't need a mic for this size of room. So I just want to caution folks that we maintain the open dialogue between and amongst sides of the agency, because we'd love for that to run in sync, meaning if we're developing a report, it should be the same report. It would be very difficult to create new forms of reporting for OCA versus HPD if it's trying to get at the same issue. So thank you.
Thank you. Continuing public comment, looking to individuals in the room to step to the podium. Those online, please raise your hand. Noting we have about 60 attendees online. Seeing no hands raised, going back to the room to the individual at the podium. Please go ahead.
Hi, Ben Johnson, California Hospital Association. Just a couple brief comments. Disappointed to not see more proactive steps to really improve standardization and transparency of the reported data, especially as it's being attributed to providers. So would seek further changes there before this regulation is finalized. Second, as we've talked about in various letters, we are disappointed that the office isn't pursuing clinical risk adjustment and continue to push for at least the collection of that data at this point so that the state can properly evaluate multiple forms of risk adjustment with regards to the spending target program. And then finally, just seeking additional clarity on how the office is intending to collect Medi-Cal data from DHCS, both on the managed care and fee-for-service side, and ultimately fuse that data with the other reported data. Thank you.
Thank you. Continuing public comment. For individuals attending virtually, please raise your hand. Those in the room, please step to the podium. Seeing no hands raised and no one at the podium, that concludes public comment on this item. Moving to agenda item number 8, I will turn it over to Deputy Director Vishal Bhagani.
So this agenda item is hospital measurement. We'll have an introductory discussion of OCA's plan for measuring hospital spending. Before I introduce our consulting team, I'd like to give some context for OCA's plan for measuring hospital spending. The total healthcare expenditure or total medical expense measurement approach was step 1. We initially focused on THC data collection from payers and fully integrated delivery systems because they must submit data by September 1st of 2024. Collecting baseline data from payers and fully integrated delivery systems allows OCA to gain understanding of payer reporting capabilities. So OCA does not impose unnecessary reporting burdens on other healthcare entities like hospitals and other providers. Total healthcare expenditure data collection will be an iterative process requiring periodic updates in additions to the attribution addendum, which lists physician organizations for which payers are able to attribute total medical expenses. Exploring approaches to hospital measurement is step 2 and aligns with the statute's timeline for measurement of healthcare entity performance against the target. Now I'd like to introduce the team from Friedman Healthcare who are helping with OCA's plan for measuring hospital spending. First, Dr. John Friedman, and they're approaching, First, Dr. John Friedman, President and Chief Executive Officer of Friedman Healthcare. is an internist by training and brings 25 years of experience in performance measurement and improvement and healthcare market dynamics. Mary Jo Condon, a principal consultant with Friedman Healthcare, supports OCA in its primary care, alternative payment model, and behavioral health work streams, and supports several other states in their efforts to use data to improve healthcare value. Sarah Lindberg is a senior data science consultant at Friedman Healthcare. Prior to joining, Ms. Lindberg spent over 6 years working for the state of Vermont's chief healthcare regulator, the Green Mountain Care Board. Sarah oversaw the establishment of 15 hospital budgets, assisted in the development of financial targets for Medicare and Medicaid in Vermont's all-payer ACO model, and managed the state's healthcare database. Lastly, Gary Swan, a senior consultant at Friedman Healthcare, brings a decade of experience in state healthcare administration and leading provider organizations. At the Washington State Healthcare Authority, Gary implemented innovative CMS population health payment policies, engaged FQHCs in the design and implementation of a new alternative payment model, and collaborated closely with rural health system stakeholders. And I'll now turn it over to the FHC team.
Now, can you hear me okay? Excellent. Thank you, Vishal. As Vishal mentioned, my name is Mary Jo Condon. I'm a principal consultant with Friedman Healthcare. And today I'm going to introduce a discussion of OCA's plan for measuring hospital spending. So, as you have discussed in several of your previous meetings, measuring progress towards spending targets typically focuses on calculating total medical expenditures, or essentially how much a population spent on healthcare services. So far, those conversations have focused on looking at spending for a population covered by a payer, or spending for a population attributed to a healthcare entity, such as a physician organization. OCA's current approach will measure spending performance for hospitals that are part of a health system with attributed lives. However, OCA will need additional strategies to understand hospital spending across all patients and how that spending is contributing to the state's progress towards achieving the statewide spending target. So next slide, please, or I'll try this. Let's see. Oh, yeah, it works. All right. So want to begin with a little bit of common language. Yep, I did. All right. So for the purposes of our conversation today, when we refer to hospitals, we're really referring to a facility that provides emergency department services, inpatient services, outpatient surgeries, all those types of care. When we talk about physician organizations, at least for our purposes of our conversation today, we're thinking about a group of physicians and other healthcare professionals who provide a wide range of medical services. And then when we have our health systems, so for today, again, we're defining those as a network of healthcare facilities that provide those wide range of inpatient and outpatient services, as well as professional services. Essentially, it's when a physician organization and a hospital are under the same organizational umbrella. All right, so here are a few goals for what we'd like to accomplish over the next several months of work. First, we want to better understand the methodologies that are currently available. We want to think through their trade-offs and specifically how those trade-offs will generate advantages or disadvantages specific to California. Next, we want to evaluate the data that would be used to support specific methodologies and any challenges that might arise in terms of data collection or reporting. And then we want to use that information gained to recommend an approach to measure and track how hospital spending is contributing towards the state achieving its spending target. Last, we're going to provide some policy recommendations to support accountability. I want to emphasize that OCA will be working on all of these steps with input from stakeholders, including its board and all of you on its advisory committee. And there's going to be some other opportunities for stakeholders to engage as well. And my colleague Gary Swan will talk through those in just a few minutes. All right, let's go to capturing spending. You got it? Perfect, thank you. Okay, so on this slide, we wanted to show how the various measurement approaches all contribute to measuring progress towards a statewide spending target. So on the left, you will see that we have the methods that have been discussed previously. Basically, measuring total medical expense for a population of patients that are either covered by a payer or attributed to a physician organization. On the right, you have the measurement approaches that we'll be working on next, specifically looking at the role of hospital spending and how that spending is contributing to the state achieving the statewide spending target. This type of evaluation is often focused on changes in hospital prices, but can also look at changes in total payments to hospitals. Can we go to the next slide? Okay, so this slide demonstrates why it's important for OCA to monitor hospital spending as it works to slow healthcare spending growth. The data in this pie chart comes from the Centers for Medicare and Medicaid Services. And as you can see there in the orange, nearly 40 cents of every dollar spent on healthcare is spent in California is spent on hospital services. Let's go to the next slide. As you can see on this slide, growth in hospital prices is a significant driver of healthcare inflation. And I think there's another really important story on this slide as well. If you look at the items in red, you'll see hospital services, other medical services, education, childcare, food, housing. These are the things that our society and our families can not live without. These are really the non-negotiables. And so as you see, the rising prices for these services are unsustainable because if you notice, the average hourly wages are actually that bottom line. They're on that list. All right, let's go to one last slide for me, and then I'm going to turn it over to my colleagues. Just a little bit more common language here. So cost, price, and total spending can mean different things to different stakeholders in different situations. So for the purposes of our conversation, when we say cost, specifically hospital cost, we are referring to the total fixed and variable expenses to provide a service, including the supplies and the staff and all of the overhead. When we say hospital price, what we're really talking about is the price for a unit of service. And then when we say total spending, we're looking at those prices paid for each service, multiplying them by the number of units of service, and also looking at the intensity, because there's different prices paid for different types of services. And now I'd like to turn it over to my colleague, Senior Data Consultant, Sarah Lindberg.
Thanks, Mary Jo. So here we have really just a visual representation of the concepts that Mary Jo was just discussing with us. And here we see three different lenses of total medical expenditures. So the biggest kind of box is the payer, and the payer is going to have that information for both attributed and non-attributed patients. As part of your THCE data collection, payers will be sharing information on total spending, including the spending on hospital services for patients attributed to physician organizations. However, the lens of total hospital spending is not going to completely overlap for that reason, as Mary Jo just discussed. So measuring the real aggregated spending at the hospital level is important for the reasons we just mentioned. So hospital services are a significant share of your overall healthcare expenditures, and the prices have been increasing rapidly. Next slide, please. So we'll turn our attention to some California specific data. The data here are provided by the RAND Corporation, which is a nonpartisan resource organization that develops solutions to public policy challenges. Their portfolio includes many industries, including healthcare. And in 2022, they released this information related to hospital price transparency to better understand its impact on employers. So they compiled, this is the 4th round that they just released, and it includes data from self-insured employers, 11 state all-payer claims databases, and several national health plans. This ends up representing more than 4,000 hospitals in every state from 2018 to 2020. Each claim that was paid by a commercial plan was repriced using what Medicare would have paid based on their grouping and pricing algorithms. For California, reliable data were reported for just over 200 hospitals for inpatient care and 256 hospitals for outpatient care. Now, while these data are largely comprised of self-funded employer claims capturing fee-for-service payments, they are directionally consistent and speak to the larger trends we're seeing in hospital spending, as well as the importance of the work ahead of us to better define these metrics and measurements so that we can accurately capture hospital spending as a whole. So the next slide is a visualization of what they found on the inpatient side. This is the full data set for hospitals with at least 30 observations, and the hospitals in California are highlighted in blue. As you can see, the median commercial prices in California were 222% of what Medicare would have paid for comparable services, which exceeds the national median of 206% by 8%, so 8 percentage point or an 8% increase over that national median. We see a large amount of variation in this data set. The distribution is distributed both in and outside of California, but we see it's largely bell-shaped or evenly distributed between 0 and 600% of Medicare prices at the upper end there. And if we look to the next slide, we'll see the same review of the data, but on the outpatient side of things, with California hospitals once again highlighted in blue. Here we see the median commercial prices for outpatient services in California were 344% of Medicare for equivalent services, which is 40% greater than the national median of 246%. We see on the outpatient side an even wider range of prices among hospitals, both inside and outside of California, starting at about 100% of Medicare prices, with a long upper tail extending to over 1,200% of Medicare prices. I think that these slides underscore the necessity for better data and more precise metrics to improve our understanding of this information and its impact on Californians. I'm now going to pass the presentation over to Dr. John Friedman, President and CEO of Friedman Healthcare, who will talk about potential measurement methodologies and what we should consider for each of them.
Thank you, Mary Jo and Sarah. If someone can move, oh, there you go. You got to the next slide already. Excellent. Thank you. So I'm going to talk about how do we get to actually measuring these prices that we need to look at in a way that's fair. So I'll start with that. There's basically 2 approaches that can be used to measure prices, and they've got, unfortunately, polysyllabic names: direct standardization and indirect standardization. But basically, I'm going to try to walk you through what those are and what they're different. They're both widely used and widely recognized. They both have a lot of similarities. They both compare prices based on a standard set of services. They're both a measure of the negotiated price, that is the allowed amount from the payer. Both of them, if desired, can be adjusted based on other risk factors such as demographic or disease characteristics of patients. And both allow for comparisons over time within geographies across different categories of interest. But they differ in that direct standardization does not account for the unique mix that any individual hospital may have in a given year. With its own particular array of services. So it means that changes in services or changes in volumes over time don't get factored into direct standardization. Conversely, indirect standardization accounts for these differences and the changes over time. Each has its advantages and each has its drawbacks, and the choice depends on different factors, including what data are available to you, but we'll go through what those can be. So let's go to the next slide, please. Let's talk first about direct standardization. And so it compares prices as a market basket. And one of the best known market baskets, direct standardization, that most of us should be familiar with is the Consumer Price Index, for example. So the market basket is a standard set of services that have been deemed to be representative of the market and their average price. Direct standardization assumes a consistent mix of services. It does not reflect changes in pricing that result from differences in shifts of the service utilization. In other words, if a hospital changes its service mix over time, comparing it to that in the market basket, it will not capture the impact of those. Some trade-offs and policy considerations mean that if a hospital's service mix diverges either from the standard market basket or its own mix over time, then it may become less indicative of what its pricing really is. The Consumer Price Index, as I mentioned, measures the average change in price over time for a market basket of consumer goods and services, and this is very similar, which makes it very understandable and readily understandable to a lay audience. This method can be applied to whatever we want to measure, inpatient, outpatient, professional. And as said earlier, direct standardization is constrained to the services that are put in the market basket, what gets selected to be included in there. It does not consider variations in the service mix. And that, because of that, it might inadvertently advantage or disadvantage a hospital, depending upon how its mix changes over time. All right, with that, we can go to the next slide. I'll give you an example of this. So this is an actual example from Massachusetts. The Massachusetts Health Policy Commission looked at the prices of hospital outpatient services. And so in this figure, each bubble represents a Massachusetts health system. The bubble size gives you a proportionate size of that health system. So the large orangish ones are the large dominant providers, and some of the smaller dots are smaller systems. And on the x-axis is the hospital outpatient price, and on the y-axis is the growth in price going on the y-axis. So it gives you a quick comparison between changes in outpatient service prices and maybe helps draw some conclusions around the growth of outpatient services and the overall impact on healthcare expenditures. Next slide. The opposite way of going about it, or a different way of doing it, is indirect standardization. And what that does is it also uses a standardized set of services, but unlike direct standardization, it adjusts for that hospital's actual utilization and how that utilization varies over time. So there's, again, some trade-offs for consideration. It does account for the changes in service mix, so it will prevent skewed results. Considering that you adjust for each hospital's unique service changes, including a broader universal set of services, may make it more difficult to identify cost drivers because the driver will be different perhaps for each institution. As with direct standardization, you can apply it to any of the spending categories you want: inpatient, outpatient, and professional. And this mitigates against the process of unfairly benefiting or penalizing a hospital based on their particular mix of services. Okay, next slide. So, and here we've got an example. So this was some work that we supported in New York State, looking at the relative prices of different types of hospitals. So here we're looking at whether or not prices were driven by clinical quality, market leverage, or to what degree the hospitals were disproportionate share hospitals, that is, to what degree their revenue is derived from public payers. In the analysis, a blended price of inpatient and outpatient services was created for each hospital. So, for example, you'd see what the price of knee surgery and appendectomy, it might be the same for two hospitals for one of those services, but different on the other one. The relative price is calculated by blending them together, enabling you to have a single relative price to assess the extent of price variation. So each hospital's relative price is also adjusted in this example for the sickness of the population or the service mix. So again, this is just an example. You see these numbers. The academic hospitals in general have got a higher average relative price, and of the community hospitals, the very smallest ones are a little bit more expensive. The medium ones are have the lowest prices weighted using indirect standardization. Next slide, please. Another example on indirect standardization here. This is data from California. So we looked at the hospital financial data from the hospital financial reports that are submitted here annually and looked at net patient service revenue by inpatient discharge. And what we did is actually adjusted it by the severity, by the case mix severity. And so what this does is it reports out what the average price of a hospitalization is in thousands of dollars, starting with about $18,000 a case in 2014, going up to about $27,000 a case in 2021. Next slide. So to compare the two of them, this is an example that I want to walk you through. It's got numbers. We're going to do a little bit of math, but try to bear with me. And what I'm going to do, just as a heads up, is I'm going to go horizontally across an example of one hypothetical hospital that gets measured over 4 consecutive years. And as you'll see, in the first 2 years, both the direct and the indirect standardization method will give identical results. But in the latter 2 years, they won't. And so I hope that this is an example, both so you can see how the method works and where they would differ. And so starting there in year number 1, if you go across, you'll see that basically this hospital is a simplified one. It only provides 2 services. They either treat heart attacks, myocardial infarction, or they deliver babies. Those are the only 2 services that they do. And it turns out that they do an equal proportion of them. In year 1, they do 100 heart attacks, they do 100 babies. And, you know, that's the market basket, by the way, assumes a 50-50 mix. So what we do is we look at what are the actual prices for those services that the hospital gets compared to a benchmark price. And in the example of myocardial infarction, heart attack, their price is $2,000. If they do 100 cases at $2,000 a pop, that's $200,000 in revenue, which you see underneath the green revenue box there. And similarly, under vaginal delivery, they do 100 deliveries at $2,000 a delivery. That's $200,000 in delivery revenue, okay? The benchmark price that they're being compared to, and by the way, the benchmark could be the historical price of this hospital, it could be the Medicare price, it could be the California average, but whatever it is, the benchmark they're being compared to is $1,000. So obviously this hospital has a higher price than the benchmark. Well, if you add up what they should have collected if they charged the benchmark price, they did 200 cases, 100 each of vaginal deliveries and heart attacks. At $1,000 each, they should have had $200,000 in revenue. But in fact, they had $400,000 in revenue, $200,000 from each of those 2 cases. And so if you look at that ratio, $400,000 divided by $200,000, that's 2 to 1. So it basically says using indirect standardization, they are twice as expensive as benchmark, okay? And if you look at direct standardization, you get the exact same result because under direct standardization, you'd expect them to charge $1,000 each for that same mix of 50-50 heart attacks and babies, and they're twice as expensive. So this hospital is twice as expensive for all of its services. Whichever of these 2 methods you use, their ratio is 2.0, okay? Maybe I'll pause there for any questions, but it would be important to make sure you got that before I go further. I'm seeing some nodding heads. Okay, so let's go to year 2. The only thing that changes in year 2 is the hospital cuts its price on one of the services. But the service mix is the same. They still do 100 heart attacks, 100 babies. But they've cut the price of the heart attack care to $1,000 a case. And so they've cut their revenue on that. So instead of bringing in a total of $400,000 in revenue, they bring in $300,000 in revenue. They brought in $100,000 on heart attacks and $200,000 on babies, a total of $300,000. Again, the expectation against the benchmark at $1,000 would have been $200,000. So their result now is that they're 1.5 times as expensive. So the good news is their change year over year as their pricing went down 25%. So that's great from a cost trends perspective. And again, because the mix that this hospital actually does, which is 50-50, matches the market basket of 50-50, the results for both indirect standardization and direct standardization are identical. It's 150%, and it's down 25% from the previous year. They are twice as expensive as the benchmark for half of its service. Okay. Now where it gets a little bit more interesting, year 3, is where the mix changes. And this happens over time. Hospitals will lose an important surgeon. They will expand their cardiovascular department. They will shut down their obstetrical service. A competitor will open nearby and steal a bunch of their business. So mixes change over time. In this particular case, we've made the assumption that this hospital is now doing fewer heart attacks. They're only doing 50, but they've made up the volume on deliveries. So they're doing more babies, 150. Their volume is the same. They're still doing 200 cases, but notice that they're doing more of their expensive services. They're doing fewer of their $1,000 heart attacks and more of their $2,000 babies. And so once again, you do the math, you multiply out 50 cases times 1,000, you expect 50,000 in revenue from the heart attacks. 150 times 2,000, you expect $300,000 in baby revenue. And so what they are now is, after adjusting for that, they're bringing in 75% more than the benchmark suggests they should be bringing in, 1.75 times that amount. So that represents an increase. Since they went from 1.5 to 1.75, that's a 17% increase year over year. However, that's only if you adjust for the actual mix, the change in mix which they had, which is really important here. The direct standardization, which uses a dumb market basket, assumes that they had the same mix. They were still doing 50-50 babies and heart attacks, which we know is not accurate. And so the direct standardization still thinks they're 50% more expensive, not 75% more expensive. And so it thinks their cost trend is 0. And then just to complete this example, we'll flip it the other way. The following year, things change. They do a lot more of their less expensive service. They do 150 heart attacks and only 50 deliveries. And you'll see how the numbers turn out. Their revenues go way down because they're doing a lot more of their lower price service. And so when you adjust for the service, they're only bringing in 25% more than you'd expect if they charge the benchmark price. So indirect standardization says, well, you're only 25% more expensive than the benchmark. But again, the market basket, which ignores their actual volume and assumes that they're a 50-50 mix, still thinks they're at 1.5. And so in this case, the market basket will think they are more expensive than indirect standardization. So the bottom line on this is that as mix changes, you get important variation in what the true sense of the price is. And that if you don't adjust for those changes, you can inadvertently either say prices are going up when they're not, or say prices are going down when they're not. You want to avoid that. So once again, let me pause. There was a lot there. So I'll be happy to take any questions on this. I think I've intimidated all of you. I hope not. All right. All right. So I think that's all for me. I'll leave you confused and hand you over to Gary Swan, who'll take it from here.
So I'm here to wrap us up for the day. So in the upcoming months, we plan to assemble a technical advisory panel. Oh, next slide, please. Yeah, there we go. We plan to assemble a technical advisory panel of experts tasked with reviewing the methodologies and measurement tools at our disposal. Their insights will aid in evaluating the strengths and weaknesses of each approach. FHC will collaborate with OCA to develop and refine a measurement strategy. In the short term, we will begin data discovery to pinpoint various data requirements and perform initial data analyses using the available information that we have at hand. As we begin to define specific metrics, we will model each approach and measures for both the technical advisory panel, the board, and the advisory committee. Once the technical advisory panel convenes and we conduct preliminary assessments, we'll provide updates to this body and the board on a regular cadence. Next slide. Highlighting our work over the next several months, we aim to identify members for the technical advisory panel and convene the panel. And we'll begin preparing in-depth materials for their review and guidance. Our agenda includes testing and modeling various measurement methodologies throughout 2024, identifying methodological gaps and data needs, and formulating recommendations to overcome potential measurement challenges. If additional data collection is needed, this effort may result in new regulations beginning in 2025. I think that's what we have for you today. And I'll hand it back over to the OCA team.
Any questions from the committee? Comments or questions? Yes, Joan, go ahead, please.
Well, this is going to be fun. Looking forward to digging in on this with you. And just do want to flag a couple of things to think about on the front end. One, as you are convening the technical expert committee, I would encourage you not to just look to the obvious suspects of the industry. I think that there are very smart people who have thought about hospital financing throughout the stakeholder community. So appreciate those nods. That's exactly. And then really appreciated the bullet of this will be different for health systems. By my just very quick math, more than 3/4 of the beds in California are in health systems. And what we don't have is the provider map to the health systems. And since this entire process is about the folks who aren't, the patients who aren't in that health system linkage, have you thought much yet about how to get a better handle around identifying which patients are referred through a health system linkage?
It's really hard to do. There are different approaches to it. And one of them is to create a provider registry system where every provider larger than a certain small threshold must provide updated information about exactly who are your providers, what are the specialties, what are the arrangements, et cetera, and enhance that. Theoretically, that data exists in licensure data, but in reality, it doesn't, and it's woefully outdated. So I think that's worthy of a considerable amount of conversation, because ultimately we'll need to get there, but we're not going to be there on day one.
Yeah, I just think back to the statistic that there are 0 independent cardiologists in the Bay Area. All of them have been bought up by either the plans or the systems. And how you parse, because a referral from a delegated primary care group to a system, to a hospital that shares a name with that primary care group is a pretty straightforward mapping. But I think we've got to capture all of that. Otherwise, we're going to kick folks over into this much more complicated methodology. So yeah, looking forward to that. Also looking forward to how you take into account all of the supplemental payments that flow through the hospital system, both for the system attributions and the non-system attributions.
Exactly, and that's one of the challenges. There will need to be an attribution method of how do you allocate those funds, and that's going to be part of the process.
Good luck.
Yeah, thank you.
Yeah, just Joan, for our total healthcare expenditure data collection process, we do have an attribution addendum that does identify physician organizations, and some of those are going to be affiliated with health systems. So, but we haven't received the data yet, so we'll see kind of how much attribution can occur for health systems. But yeah, we're going to have to, just as this presentation outlined, we're going to have to build out additional measures.
Yeah, I appreciate that. I think that attribution addendum is going to be most successful on hospital stays that come through the primary care system, and we'll need to do a lot more data work on hospital stays that are generated through specialty physicians that are affiliated with a system. So a primary care physician working with an expectant pregnant person, that's a pretty direct line. But once you are engaging an oncologist or a nephrologist, they may well be system affiliated, but that may not show up in the attribution because it's not a delegated.
And one clarification on the work that we'll be doing that may be helpful is that we're not going to be focused just on those who are unattributed. We'll be looking at attributed and unattributed. It's just that through the THCE data collection, you're going to have additional information on the attributed. So I think one of the benefits of this work is that full population view.
Thank you. We'll go to Andrew.
Yeah, so I guess this is more curiosity on the methodology because, you know, I'm from Kaiser. All of my and everything is kind of attributed. I guess I would say, you know, OSHPD, you know, HCI has a rich history of hospital cost data, right? So I guess I'm just trying to think about what are we measuring, right? What is the methodology? I mean, what are we trying to measure? Is it really? I guess I'm going to basically, in my very simple mind, right? You're looking at, you know, cost, you know, total cost of care per member per month, you know, in a fully delegated situation. You have the membership, right? That's kind of your denominator. Your problem on the hospital side is you don't have that denominator, right? Your denominator is basically adjusted patient day. But isn't there a, I guess I'm, given the richness of the data that, you know, HCI, formerly OSHPD, already has, is there, you know, I guess, are we overcomplicating this? Can we just look at the data? Very rich data. I love those Excel pivot tables, by the way. I've been mining those since 2008. But, you know, it's, I mean, there's just a lot of data on cost. And I think going through price and dealing with these weighting and all this stuff is very indirect ways to get to cost. You have the cost.
Yeah, thank you, Andrew. That is an important consideration of leveraging existing data for the HCI annual financial disclosure. So that's going to be part of this process.
Thank you. We'll go to Anthony and then Barry.
I think I might just want to second Joan's comments on just first of all, just overall the importance of this project, right? And I think we're just trying to get a better handle on the costs of our healthcare system, and hospitals are a really big part of them. And for the patient experience, it's the biggest bill anybody will ever get in their entire life. And at the same time, in California, the patient experience is that they are usually affiliated with a hospital through the sort of the medical group or structure that they happen to be in. You know, here in this region, if they're at UC Davis Medical Group or Sutter Medical Group or with the ones affiliated with Dignity, then there's a connection there. And so how do we just acknowledge that? So, and not for the point of complexity or not for the point of burden, because I do think if we can do this simpler, it would be better than to do it more complex. It is just to try to make sure that we don't have data that takes us down the wrong path in terms of what we're looking at, because again, there's maybe something to be said for the system, and how do we get the information at the system level that then maybe tells a story that might be different if we're just looking at the hospital. So I just appreciate what you're trying to do, and thanks for walking through the math as well.
Thank you. We'll go to Barry and then Parker.
Well, I will echo the comment. Appreciate you helping us walk through the math. It's very data rich, and I appreciate that. Just a couple of questions quickly. On the chart, we've seen variations of it over the course of time on divvying up all healthcare cost in the pie chart, and the hospital care is the biggest. It sounds as though that your process will be able to parse out those aspects that are attributed to hospital care that are prices not under the control of the hospital. High-cost medical devices that flow through the hospital are called hospital care. They show up nowhere else. High-cost pharmaceuticals, the most expensive, are typically administered in a hospital, and the hospital doesn't control them. And supply costs, which in the last few years tripled the regular inflation costs. You'll be able to parse those out so we can better understand what costs are attributable to under the control of the hospital.
The first step is to find out what are the costs. The next step will be what are the drivers, and what is attributable. So I don't know that we'll be able to get that because it's going to depend on the data. What we would have, however, is, for example, let's say hip replacements. If hospital A is using much more expensive supply charges for their hips than hospital B, that may end up being reflected, or if they change it over time. Year one, they use the inexpensive stuff and they get a new contract with somebody for much more expensive stuff. It will look like a detriment to their cost trend. I mean, that'll just be the reality. I think you raise a fair question as to, well, then what are we going to do about it? Which of these things are going to be within control or not within control? Some of them are, some of them are not.
Thank you. And then a second question on the scatter charts comparing commercial prices to Medicare. Do we use Medicare because it's just a convenient, easy to understand benchmark, albeit reimbursing under the total cost of care, or because we think it's a reasonable, sufficient reimbursement?
Sure. If you know another benchmark that works in all 50 states.
You can answer the question.
Yeah, exactly.
It doesn't much matter how Medicare reimburses hospitals below the cost of care. We're not saying that's appropriate. We're just saying it's easy.
Yeah, and one thing that's really interesting about the RAND work in particular is they measure it two different ways. So there's a standardized price as well as the Medicare relative price, which says this is how much you got for commercial divided by a standard unit of service. So you'll actually find, I was perusing the California data in a publicly available data set, but it turns out that there's a hospital that has a higher standardized price but a lower relative price because they're getting a higher payment from Medicare. So we have to keep in mind that Medicare doesn't necessarily always pay the same rate. And I think that's an important factor in that analysis.
Thank you.
Thank you. We'll go to Parker and then Carmen.
Hi, thanks. And just a question that I don't know at all the answer to this, but it's about how you factor in residency costs for hospitals. Most of us assume the residencies are all attached to universities here, but that's actually not the case. A large number attached to independent hospitals, and they collect money federally. And is that a factor at all? Is that a 0.1% of this equation?
Yeah, so the method that I've described today would not account for them at all. So in one of the earlier slides that I think Mary Jo presented, one of the ways of looking at it is what's the cost? What is the cost structure? What is paid in graduate medical expenditure? What's paid in rent? What are the input costs? That's not part of what this process is. So those are obviously things that are related to what the price will be, but we're talking about either measuring expenditure or measuring price, not the underlying cost.
Carmen.
Thanks. That kind of gets to my question because I had I think this is great to try to figure out how to where hospital costs are coming from, how to attribute them to the correct providers. And I had the same reaction as Andrew is saying, like, wait a second, we have a lot of HCI data. Having been someone who's looked at a lot of cost to charge ratios, that's the thing that I'm really interested in. The big question marks for me here, other than attribution, is what is this basket that we're talking about, and what are the benchmark prices, and how are we figuring that out? Because I think ultimately at the end of the day, we're interested in making sure that the prices make sense relative to the costs, and that I think where I am interested in this is if we're looking at total hospital costs, and we're looking at some sort of standardization comparison, let's make sure that we're not kind of so that we're actually looking at the needs of the patients in the different areas in the hospitals, because perhaps, and I think this is where you're getting at between the indirect and direct standardization, is that the basket is going to change depending on each hospital. But I think ultimately, it sounds like you're not looking at the cost versus prices question, and you're just looking at the prices and comparing prices, if I'm understanding correctly. I guess fundamentally I'm trying to figure out what's the ultimate goal of this project.
Really great questions. A few thoughts. So one is just to say that today is really a beginning of a conversation, and we want to explore all of these issues with all of you, as well as with the technical group that will be brought together. And so we're really kind of today just laying out some ideas and showing how some other methodologies have sort of approached this. With regard to those points, I think, you know, we may very well end up using data that's already available. There may be data that is adjusted in some way going forward that, you know, sort of allows for the use cases that we're talking about. I also think that, you know, states sometimes develop different comparators, right? So, for example, on, you know, hospitals that have teaching programs, maybe looking at those hospitals compared to each other, you know, versus other hospitals that are perhaps unlike them in different ways, or excluding certain services because we see them as a community good, and we think that the fact that they're high cost is just the nature of that service, like transplants, for example, is often something that is excluded. So I think these are all really good questions, and we're so excited to get started on this work so that we can start to explore them with you.
Thank you. Other comments or questions from the committee? All right, seeing none at this time, this moves us to public comment, as this is the last item on our agenda. We'll take public comment on both this agenda item and also general public comment. Members of the public, please step to the podium. If you're in the room attending virtually, please raise your hand. All right, seeing no one in the room, we have roughly 50 attendees virtually, seeing no hands raised at this time. Looking back to the room, seeing no one, this concludes public comment. There we go. The next advisory committee meeting, April 23rd, 2024, in this location at 10 a.m. That concludes our agenda for today. If there's nothing more from committee members, I declare the meeting adjourned. Thank you all.